بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. والصلاة والسلام على سيدنا وحبيبنا ومعلمنا ومحمد صلى الله عليه وسلم. اليوم إن شاء الله هنتكلم على موضوعات الخاصة بالأكيوت كيدني انجري، القصور الكلوي الحاد أو الفشل الكلوي الحاد. إن شاء الله نحاول نغطي جميع الحالات اللي أنت ممكن تشوفها في الفيديو ده في حالات الأكيوت كيدني انجري، وإزاي تتعامل معاها، والبراكتيكال أبروتش بتاعك، clinical practical approach and easy approach to diagnose any patient with AKI. ونتوكل على الله. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون، صدق الله العظيم. بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا الا ما علمتنا انك انت العليم الحكيم، صدق الله العظيم. الاوبجيكتيف بتاعتنا اليوم understand definition and epidemiology and risk factor classification of acute kidney injury, use of systematic approach to determine the most likely cause of AKI, including appropriate use of diagnostic tests, appreciate the diagnostic test available, understand the principle and management of patient with AKI, and identify the complication of AKI, and appreciate the modalities of renal replacement used in management of AKI. I will be fast on the first few slides, and because we have already around more than 15 cases, and all interesting case, clinical, real cases you will face in your practice. Case number one, we'll start just by this case. Just I need you to put in yourself or in your mind this face in front of you now and referred for you. This patient, already 75 years, male patient with chest infection, with past medical history, diabetes, hypertension, coronary artery disease, CKD3, dyslipidemia, and osteoarthritis gout. CKD3A2 with the proteinuric CKD. Medication already aspirin, blavixaramogrel, Concor, or bisoprolol, amlodipine, hydrochlorothiazide, sitagliptin, metformin, lantus, Lyrica, and xyluric acid. This is the medication of our patient. History present illness: patient 4 days fever, malaise, productive cough, seen by GP, already prescribed azithromycin 2 days ago. Patient presented hemoptysis 1 day, presented to emerge with progressive short of breath and hemoptysis 1 day. When we saw the patient, already the patient unwell, temperature 38, tachypnea, tachycardia, little bit hypotension from his baseline around 140s, and saturated already 80% room air need, 5 to 10 liter non-repressing face mask, with chest examination, bilateral crackles, and lower limb edema. And her lab leukocytosis, hemoglobin stable, little bits thrombocytopenia, hyperkalemia, metabolic acidosis, and lactated 6 is high, with creatinine around 230, and calcium phosphorus little bit elevated, albumin is okay, with urine +2 blood, +3 protein traces, white blood cells, liver function normal, ABG mild metabolic acidosis, with lactate, hyperkalemia, and with CKD and leukocytosis. And her chest X-ray ratio patchy infiltration, fluffy cottons versus patchy volume versus infection. She received already 2 liter normal saline bolus in 100 ml per hour, and started tazocine, levofloxacin by ICU. And respiratory patient went to respiratory failure over 12 hours, intubated, ventilated for that from admission, because the patient was tachypnea and with tachypnea and tachycardia and a little bit hemodynamic and stable, and the patient received the fluid and went to more desaturation and more respiratory work of breathing, and need norepinephrine vasopressin to be started with progressive oliguria from 5 to 10 cc per hour. Nephro consulted at that point. Nephro, he should be called when the kidney function can start to increase, and the urine is the most indicator when the ICU call you because of oliguria or neuria and rising creatinine, and patient deteriorated patient already. What is your rule? Your rule now to diagnose the cause of this AKI. What is the investigation are needed to? What is the guided in your treatment? What is the empirical treatment needed or no? When they ensure all medication safe and renally adjusted, you should review all the medication, avoid and treat complication of AKI. Timing of renal replacement therapy should be planned when you suggest or suppose your patient will start renal replacement therapy. Avoid future AKI episodes. by avoid contraction, nephrotoxic, and control blood pressure, control blood sugar. Approach to any patient with AKI: decrease estimated GFR, decrease urine output. AKI either pre-renal, renal, post-renal, pre-renal, either decrease in the GFR due to decrease renal plasma flow and renal perfusion pressure. Renal decrease GFR directed to injury to the kidneys. Post-renal decrease in estimated GFR, obstruction of urine outflow. And if especially with elderly patient, you should rule out post-renal cause. Your tool to diagnose any AKI, just good history taken from whatever, from primary doctor, from family, whatever available, just to take a good history. Physical exam for your patient. Don't forget volume assessment, volume depletion, volume contracted GVB, chest X-ray, chest exam, and lower limb examination, skin turgor, and temperature of your skin, and don't forget to palpate suprapubic for your retention, even if your patient on folic acid may be blocked. Don't forget this point. Urine analysis microscopy in AKI, you should take urine sample and centrifugate and look under microscope to diagnose type of cast, type of cells, type whatever you will see, a type of crystals, whatever your usually suspect your patient will be. And ultrasound kidneys to rule out post-renal cause, gene workup if you have rapid rising of your creatinine, and prepare for kidney biopsy 2. Avoid any complication. The renal dose or medication should be adjusted. Volume assessment and sodium assessment, intake output, fluid chart, intake output, daily body weight, and cumulative balance per day. Monitoring per day and since admission ICU. Monitoring potassium bicarb daily. Avoid any nephrotoxic drugs, renal replacement therapy plan. Just this is just initial approach to any patient with AKI. For our patient, we established a etiology already. He's in sepsis and chest infection, and this horrible sepsis was a little bit volume overload, treated with sepsis associated with volemia, renal perfusion, and stop this all nephrotoxic medication, anabril, hydrochlorothiazide, amlodipine, and pregabalin, Lyrica, metformin, and Xyluric, and dose adjustment for all medication. Recent definition of AKI. Just I started with this case. We'll start now. Basic knowledge for any AKI. You should know, any nephrologist should know all this basic. We have rival classification and Eki classification and Eki classification for AKI. And what is in general definition of our AKIs is abrupt loss of kidney function resulting in retention nitrogenous waste product. This is our job of our kidney. Dysregulation of electrolytes, hyperkalemia, whatever, and hyperphosphatemia, and dysregulation of water and sodium balance, which will be volume overloaded, sodium hyponatremia, and dysregulation acid-base will go to metabolic acidosis. We have all this problem in patient with AKI already. And this rival classification, for this rival classification, we need risk, injury, and failure, and loss of kidney function. You know, in this stage renal disease here, need renal replacement therapy more than 3 months to write your patient in this stage renal disease. Before that, he's CKD stage 5 in renal failure. Stage 5. And otherwise, we need this classification, risk, injury, failure, just the theme we use on AKI and the KDIGO definition of AKI, but we use this already to risk of mortality in ICU, and we'll see. AKI defined by KDIGO either increased creatinine more than 0.3 milligram per deciliter or more than 26.5 micromole per liter within 48 hours. This is the first part of the definition. Creatinine 0.3 milligram per deciliter or more than or equal 26.5 micromole per liter within 48 hours. Increase in serum creatinine more than 1.5 or 50% from the baseline of over 7 days, 1.5 or 50%. Urine volume decrease less than 0.5 milli per kg per hour for 6 hours. This definition, all of us know that. And we have 3 stages of classification, 1, 2, 3. 1 from 1.5 to 2 times from baseline. This from 2 to 3 times from baseline, more than 3 times from baseline, with urine output less than 0.5 milli per kg per hour for 6 hours, more than 0.5 per kg per hour for more than 12 hours. Here, less than 0.3 ml per kg per hour for more than 24 hours. And the stage 3 here, if the creatinine increase more than 350 micromole or 4 milligram per deciliter from a baseline. And these are 3 definition or 3 stages you should put in your mind to classify any patient with AKI. Just to simplify the last table, stage 1, stage 2, stage 3, creatinine increase more than 26, more than 50%, or urine output less than 0.5 over 6 hours. And stage 2, more than 100% from baseline increase in creatinine, urine output less than 0.5 ml per kg per hour for 12 hours. And stage 3, serum creatinine increase by 200, or urine output less than 0.3 ml per kg per hour for 12 hours. And this just collection for arrival and leaking classification. You can read later. Only creatinine here depend on for this definition for creatinine and urine output. This is rifle as I mentioned for you, rifle classification for acute kidney injury predicted mortality. If no AKI, this retrospective cohort study review 5,000 patients in 7 ICU and found if no AKI, mortality will be lower than patient with already in the stage renal disease or kidney failure. This is around 26% from 5 without AKI. With the causes of AKI, we have risk factors are patient in sepsis, critical illness, hemodynamic and unstable, a patient after cardiac surgery, and nephrotoxic and radiocontrast poisonous, all this risk factor for AKI. And who's high susceptibility for AKI is patient with volume depletion, dehydrated, old age, female gender, black race, CKD, especially CKD patient, chronic disease, whatever other organs, diabetes, cancer, anemia. Limitation, we know creatinine is variable because patient in sepsis and low muscle mass and other patient with delusion will give you a wrong number. We need this correction factor if you remind from physiology. Just to give you adjusted creatinine according to muscle mass or volume or patient diluted. This correction factor equal total body water plus daily cumulative fluid balance divided by body water. Body water plus daily cumulative fluid balance divided by admission body total body water. Adjust creatinine will be equal serum creatinine multiplied by this correction factor. Okay. Long-term outcome of AKI, you know, AKI around CKD will be hazard ratio more than 8.8. In the renal disease hazard ratio will reach 3 and mortality more than 2. All this with high hazard ratio in this meta-analysis study. Did the long-term outcome CKD in the renal disease and the mortality CKD around the hazard ratio around 8 is too high, and the renal disease 3 and the mortality is there is also higher risk for cardiovascular disease and congestive heart failure too. Long-term outcome, as we mentioned, CKD and the renal disease, cardiovascular mortality influenced by severity. Indeed, they increased already enhanced by severity of AKI, recurrent episode of AKI, even recovered AKI increase in long-term risk. How common AKI is around 1% of hospital admission, complicate 7% of hospital admission. Cause of 1% hospital admission and complicate 7% of hospital admission. Either 1 per 100 patient or 7 per 100 patient hospital admission will be develop AKI. On overall population, around 550 per 100,000 per year. Classification is the regular classification, as we know all AKI either pre-renal, renal, post-renal, and the renal here divided into vascular compartment and glomerular nephritis, GN, interstitial nephritis, tubular necrosis, either ischemic, toxin, pigment, and we'll see cases for all that. This approach, as I mentioned before, pre-renal, renal, post-renal. Pre-renal reduce the effective extracellular fluid volume, as we know, hypovolemic hemorrhage and cardiac failure, systemic vasodilation, sepsis, cirrhosis, hepatorenal. Impaired renal autoregulation as non-steroidal is common for us. This is when efferent vasoconstriction, also cyclosporin and contrast, decrease GFR, and also efferent vasodilatation by using LAS lead to also decrease intraglomerular pressure. Vascular, either renal renal or large renal artery vein occlusion or vasculitis, thromboembolic, and other diseases can lead to renal AKI. GN as a primary or secondary systemic lupus lead to AKI, ischemic ATN, as we mentioned before. Interstitial either drugs or other autoimmune infection, malignancy, infiltrate lead to interstitial AKI. Toxic either endogenous or exogenous like alcohol or contrast, endogenous like rhabdomyolysis, bilirubin light chains, uric acid hypercalcemia, intrarenal obstruction like cast and the crystals, contrast tumor lysis syndrome, all this lead to intrarenal obstruction. Obstructive uropathy either from pelvis, kidney or pelvis, from ureter bladder, from bladder urethra, all this lead to prostate already enlargement, all this lead to obstructive uropathy. Epidemiology, AKI is a common medical problem among hospitalized patients. 18 pre-renal AKI are the most common cause of AKI in hospitalized patient. AKI is associated with increased hospital mortality and increased risk of readmission. AKI increased long-term risk of developing CKD and end-stage renal disease. AKI 18 pre-renal AKI is the most common cause AKI in hospitalized patient. Frequency pre-renal more than 60%, renal 35%, post-renal 5%. The most common one is pre-renal ATN. This slide only I need just one home point or two home points, just creatinine from where? From either urine food, from meat or from liver or pancreas. Either some part from kidney. This is the creatinine product. From where the creatinine? From meat, liver, pancreas, and the kidneys. What is the component of amino acid for creatinine? Amino acid arginine and the glycine. Arginine and the glycine. And the creatine will go to phosphorylation, phosphocreatinine inside the muscle for ATPs here. And at the end, while creatinine here will be cleared by the kidney by GFR. Okay. Molecular weight 113 Dalton, freely filtered, not absorbed, but secreted in the tubules, the kidney tubules, the proximal tubules. Freely filtered, not reabsorbed, but secreted, okay? Half-life normally around 4 hours. Patient with low GFR, maybe 24 hours, 72 hours. Daily excretion for the creatinine, for the male around 20 to 25 milligram per kg per day. For the female, 15 to 20 milligram per kg per day. In maximum 200 microgram for both micromole per kg per day. 200 micromole per kg per day, but here 20 to 25, 15 to 20 milligram per kg per day. الكرياتينين طبعا little bit هي stable already, steady الكرياتينين turnover is steady in healthy patient. But already creatine turnover affected by illness, sepsis, factors that affect the muscle mass turnover, malnutrition, obesity, nephrectomy, amputation. All this will give you low creatinine, glomerular damage, and tubular dysfunction. Trimethoprim, trimethoprim impairs secretion. Creatinine is one of the side effects of trimethoprim, especially in transplant patients. This will impair secretion of the creatinine to proximal tubules and lead to high creatinine. This factor also affecting serum creatinine interpretation. You can read all this, like I mentioned, food intakes and rhabdomyolysis and other medication, trimethoprim. All this will affect the creatinine. To evaluate any patient with AKI, either from history, urine output, infection, drug history. Physical exam, hemodynamic fluid status, temperature, and bladder. Just don't forget this urine retention during examining your patient. Just check his suprapubic area not fully distended, and check your folic acid. Even patient folic acid may be blocked. Yeah. And assess urine output per hours, this daily fluid chart and daily body weight, and consider folic acid for any patient with AKI. Ultrasound kidneys to rule out any obstructive uropathy. And assess the kidney size, may be possible kidney biopsy in future also. And this is traditional lab, serum creatinine, urea, electrolytes, acid base, CBC coagulation, CBK, LDH if indicated, and other blood culture virology. And the immunological workup, serology, C3, C4, anti-nuclear antibodies, and double-strand DNA. And hepatitis C serology, as we mentioned, toxicology screening if you suspect that. Urine analysis, we are taking urine just to do deep stick for albumin and protein, especially albumin. and the pH and the leukocytes and the red blood cells and the blood also. And the microscope, under microscope, we'll see different type of cells, the leukocytes, white blood cells, epithelial cells, and red blood cells, and the different cast, hemogranular cast, hyaline cast, red blood cell cast, white blood cell cast, according to the type of cast and the different type of crystal you can see also under microscope. And urine chemical analysis and urine culture of suspect your patient is AKI, as we mentioned before, folic acid, urine output, ultrasound, don't forget that. And this differentiation, all differentiation is common in MRCP exam, pre-renal, post-renal. Pre-renal, everything will be high, urine specific gravity and urine osmolarity, except urine sodium will be low here. Fractional excretion sodium, if not diuretic, if no diuretic will be less than 1, if with diuretic will be more than 1. In fractional excretion, uric acid also less than 7 and urea less than 35. Urine sediment, as I mentioned before, this different sediment, red blood cells, dysmorphic red blood cells, and the other white blood cells like that. It will give you just a prognosis and the diagnosis clue for your patient if you found the dysmorphic red blood cells and the red blood cell cast. This was AG with GN and maybe RBGN. You should deal active with this patient and proceed for all GN workup and kidney biopsy. And other patient just only with white blood cell and white blood cell causes acute interstitial nephritis versus UTI. According to urine sediment, you will see under microscope. This will guide you what is the emergency of your case. This is a novel biomarker for AKI. You know, we have stress biomarker and the injury biomarker, functional biomarker. According to his normal here, kidney and start to be injury, GFR start to be decreased, clinical AKI recovery. Here, creatinine will be start to, these molecules will be start on a stress biomarker, NIGAL and also KEM. All this will be start to increase here. And this injury biomarker, NIGALs and the KEM, and functional biomarker here will serum cystatin and the serum creatinine and urine output will be for this functional loss of biomarker, and recovery biomarker also serum creatinine, urine output and the cystatin also. All this will be decreased. This is a functional recovery biomarker, just to remind you. And the different biomarker used to detect in AKI if you have time to read. And this to remind you by this neutrophil gelatinase associated lipocalin with emergency troponin like cardiology for a marker for kidney injury. This is NIGAL 1. Especially with patient post-cardiac surgery. You know, this 25 kilodaltons, urinary NIGALs, 1 to 6 hours appears after cardiac surgery in urine, 12 to 24 hours after kidney transplant, and 2 hours after contrast, and 48 hours pre-kidney in ICU, pre-KI in ICU. Within 48 hours start to appear other novel markers, the cystatin C and the KEM marker, kidney injury molecule, KEM1, cystatin, KEM1, and interleukin 18. I need you to just remind this within NIGAL. And this cystatin, just I will give you a hint for him, 13 kilodalton produced by all nucleated cells and unaffected by age, gender, and muscle mass, unlike creatinine. Detected AKI much earlier that serum creatinine arise 1 to 2 days earlier than serum creatinine in setting of AKI. This is the advantage of this cystatin C. Just 2 days can be appeared or be raised before the serum creatinine change. Elevated urinary cystatin reflects the renal tubular dysfunction opposed to the glomerular injury. But already when you use this marker, just suppose after this ICU studies, emergency room studies, this combination of NIGAL and the KEM and the baseline creatinine, even cystatin, you should use as this perform the best for prediction risk percent better than use only single markers. For functional markers, serum creatinine, cystatin, and urine flow rate. And for kidney damage marker, we can use this NIGAL and the KEM interleukin 18. This mechanism of renal injury, just to put in your mind, what is AKI, what is your mechanism of renal injury? Either microvascular or tubular. It started by microvascular, glomerular, and medullary. With increased vasoconstriction, renal nerves, adenosine, angiotensin 2, thromboxane A2, endothelin, leukotrienes, all this vasoconstricting, it will be increased, and the vasodilator will be increased, nitric oxide and the bradykinin, prostaglandin A2 will be decreased. It will lead to increased endocellular and vascular smooth muscle damage, increase the leukocyte and cellular adhesion, vascular obstruction, leukocyte activation, and inflammation. All this will end by decrease the oxygen and inflammatory vasoactive mediators. Decrease the oxygen lead to cytoskeletal breakdown. The tubular cell will be damaged and loss of polarity, apoptosis, and necrosis. This formation of variable necrotic cell, tubular obstruction, and back leak. And with here the normal tubular epithelial cell, proximal cell, tubular epithelium, and normal epithelium, and the brush border. All this will be by ischemia and decrease in perfusion, lead to loss of polarity and the brush border for these cells, and after that apoptosis and necrosis and the damage, and it will lead to tubular sloughing and included intratubular lumen here and patchy loss of our tubular cells, and this after that will be regeneration will be happening, will take time, maybe days, weeks, months to be recovered again. And then the same normal one, the normal epithelial, and this already acute kidney injury with damage already epithelial cells here and infiltration, this normal and this abnormal. All this lead to the same mechanism before, and this just to magnify this normal tubular epithelial cell with brush border, and here already patchy loss of our tubules and the brush border and damage, and summarize the effacement and the loss of proximal tubular brush border, patchy loss of tubular cells, as we see before here, this patchy loss of tubular cell and the brush border. Focal area proximal tubular dilatation, distal tubular cast, area of cellular regeneration that appear during the phase of recovery of renal perfusion. And this is summarized for this, started from healthy kidney and start tubular injury, endocellular activation, tubular obstruction, leukocyte activation, and the vascular injury, and all this end is by renal damage, and after that will take impaired kidney repair. This will take time, so 2 days, 2 weeks, as we mentioned before. And the summary pathogenesis of ischemic AKI, endothelial and epithelial cell injury, and the necrosis and apoptosis, a change in the local microvascular blood flow by immunological and inflammatory process, disturbance of renal autoregulation, you do not TGF, tubulo-glomerular feedback. This will be happening when the proximal convoluted tubule is damaged and decreased reabsorption of sodium and the chloride. All this chloride will go to early distal tubules. Sodium chloride will be highly sensitive to macular dense and they stimulate more signals, stimulation for adenosine, lead to more afferent vasoconstriction and decrease kidney perfusion, and lead to deteriorate more GFR. GFR will be low. Loss of polarity of the cell, back leak when you have damaged tubule, the tubular epithelial cells, it'll be easy to transfer this our intratubular lights and the component from the intratubular to circulation is easily and by diffusion. Did the back leak, intratubular obstruction by this damaged cells and cell debris already. Perirenal AKI, don't forget perirenal, renal, postrenal, perirenal eyes are hypovolemic from bleeding, urinary loss, GIT loss, burn, skin loss, low cardiac output, not hypovolemic, heart failure, cardiogenic shock, massive pulmonary embolism also is a cause of perirenal cause, systemic vasodilation from mere sepsis, cirrhosis, anaphylaxis, renal vasoconstriction, drugs, calcineurin, non-steroidal contrast, amphotericin, hypercalcemia, hepatorenal syndrome. Different arterial vasodilatation is or R, as we mentioned, as I told you, is E will come now. Intrinsic renal disease, either renal, postrenal, renal, either vascular, glomerular, tubular interstitial, and this tubular interstitial, either acute tubular necrosis, interstitial nephritis, diffuse tubular obstruction, and this will divide it be acute tubular necrosis, either ischemic or toxin, either exogenous or endogenous, rhabdomyolysis, intravascular hemolysis, interstitial, either drugs induced or autoimmune Sjogren syndrome, sarcoid, systemic lupus, tubular interstitial nephritis with uveitis, IgG4 related disease, infection, pyelonephritis, leptospirosis, viral nephritis, TB, Legionella, and the cancer, myeloma, lymphoma, leukemia, diffuse tubular obstruction as a drug, uric acid, and light chain myeloma. We'll concentrate on acute interstitial nephritis, drug-induced autoimmune, infection, cancer, all this. And here, glomerular, when you have patient with rapid RBGN or concentric GN or rapid rising creatinine with unexplained rising creatinine, you should think on that. Anti-GBM, maybe immune complex deposition, and the immune ANCA vasculitis, either C-ANCA or B-ANCA. This is a differential diagnosis of RBGN, anti-GBM, immune complex, and immune ANCA vasculitis. Teen risk factor for AKI should put in your mind any age more than 75, high risk, geriatric nephrology, and CKD patient is high risk, and the previous AKI, comorbidities, other comorbidities, diabetes, liver disease, whatever, congestive heart failure, and malnutrition, sepsis, hypotension, hypovolemia, medication, nephrotoxic medication, symptoms, history of urinary obstruction is the risk factor. Prevention, AKI, most commonly controllable disease prevention and early diagnosis are the case, and will come all this by the end. Recognition of AKI, diagnosis, suspecting your patient by oliguria, start with oliguria and blood rising urea, creatinine, acidosis, rising potassium. Just if it is rapid rising, just don't forget the kidney biopsy for your patient. What should you look for when you examine your patient? Just previous creatinine, what is his baseline, what is the previous trend of his creatinine, presentation history, what details the history for him, and the full medication list, any nephrotoxic medication, whatever, vital observation, any drop in his blood pressure, whatever, any hypotension, any hemodynamic instability, this will guide you for your diagnosis, your analysis. You should take urine sample and look. Blood, CBC, and full chemistry for your patient, ultrasound to rule out obstruction and assess your kidney. Don't forget any patient with AKI oliguria, please put folic acid, and examine his bladder. Urine analysis, just will see pre-renal, renal, post-renal. Beside your clinical assessment, just the urine analysis will guide you as well come to cases. If you found by deep blood and the protein will guide you, especially with BGN or interstitial nephritis, as we'll see according to your history and the clinical examination. When you see patient with AKI, think what is the level? Has this pre-renal, has an infection and hemodynamic, or post-renal excluded by ultrasound and examination, or there is intrinsic renal disease, history of systemic disease, nephrotoxic and urine deficit, and the pre-renal is the most common one, more than 60%. We have one case, 67 years, 1 month, 3 days. This is the second case. 3 days post right total knee replacement and referred for creatinine, acute kidney injury, 160 from 85. I think double now, and urine output 400 over 24 hours. This is presented not feeling well, nausea and poor oral intake. This pre-renal cause nausea and poor oral intake. Past medical history, hypertension, ramipril, metformin, and osteoarthritis medication, hydromorphone, and indomethacin, and gentle fluid, just 60 ml per hour, 2/3, 1/3 IV fluid. This 2/3 2 D5 water and 1/3 normal saline. Okay. Now this patient, just a summary, I refer you to this patient. 70 years, I will around 70 years female, day 3, post 3 total renal replacement. I told you, Dr. X, please go to see this patient. Is referred for us as AKI, his creatinine 160 and urine about 400 ml for the last 24 hours. And the patient given history of nausea, vomiting, poor oral intake, and ramipril and many nephrotoxic medication. Please stop all this medication. And what is, does she have AKI according to definition? Yes. How the common AKI, as I mentioned before, around 7%. Approach to AKI, particle clue, etiology, medication, and the history of nausea, vomiting, and the surgery. Physical exam, the volume assessment, what is lab testing, you should check, you should put all this in your mind. In addition, post-operative, you will check operative notes and the blood loss, nausea, vomiting, this poor oral intake, pre-renal, little IV fluid. You can adjust your fluid as in your assessment, and non-steroidal should be stopped, AC should be stopped, opioid should check your retention for any patient to know opioid, because this will lead to your retention. What does hypovolemia cause? Reducing. How will hypovolemia lead to decreased GFR? Hypovolemia means hypotension. Hypotension means activation of renal vasoconstriction, sympathetic nervous system, and the RAS system, and reduce renal blood flow and decrease the GFR. Normally, when you saw normal glomerulus, already we have open tab here, and with open also open pass. Yani you will give blood here, and with also open will take the blood here. But if the patient perfusion decrease, this will be vasoconstricted. If you have hypotension, hypovolemia, this will be vasoconstricted, and this will be vasodilatation, normal response. But if you receive non-steroidal A will do afferent vasoconstriction here, and this already with this patient with hypovolemia already have vasoconstriction in his efferent arteriole. It also lead to decrease the GFR already. But if you This is the mistake. If you will give this patient now also, now you'll decrease already the blood coming here. This will end by decreasing GFR also. And the kidney try to compensate by angiotensin to close just try to preserve the intraglomerular pressure. But here, if you'll give ACE, you will do vasodilation to the efferent, and this will lead to decrease the intraglomerular pressure here, and also will lead to decrease the GFR. This is the main mechanism for ACE and the non-steroidal from a normal response. If you can read, you will understand this is normal. This is normal response between the afferent and the efferent arterioles. But if you increase sympathetic, will lead to increase more vasoconstriction to the afferent and decrease the GFR. Okay, what happens if what is the prostaglandin? What is the benefit of this prostaglandin, and what is the hazard of giving non-steroidal? We know arachidonic acid, the component of cell membrane phospholipid in many cells. It will be transferred by cyclooxygenase to prostaglandin and other vasodilator already. Prostacyclin, prostaglandin, is A2. This antagonizes the sympathetic nervous system effect. But if your patient receives non-steroidal, this will be inhibited and will decrease the vasodilator effect of this prostaglandin, and this will lead to more afferent vasoconstriction and lead to decrease the intraglomerular pressure, and they will end by decrease GFR. As we mentioned before, this is the same mechanism of you can read. An examination of our patient is to assess the volume status, low GVB, low blood pressure, rapid pulse, or static exchanges, blood pressure, systolic pressure drop from sitting to standing more than 20 millimeter mercury. This is the most important to check your patient volume status, dry mucous membrane, dry axilla, palpable urinary bladder, just check your bladder, and you can do bladder scan also. And this is the checklist for any patient to check his volume status from serous dry tongue, delay in capillary reveal, postural dizziness and weakness, dry mucous membrane, cool clammy extremities, tachypnea, tachycardia, and postural hypotension, low jugular venous pulse, oliguria, decreased mental status, peripheral cyanosis, reduced skin turgor, marker, tachycardia, supine hypotension, as we mentioned before. Don't forget any this when you examine any patient, and this reference for physical exam for if you like to read more and learn more how to examine your patient. Hormonal response to hypovolemia. Any patient with hypovolemia, what will be happening? Activation of RAS and CNS, with increase in intratubular reabsorption of sodium and chloride, reduce the urinary sodium and chloride, activation of antidiuretic hormones, increase tubular reabsorption of water, increase urinary concentration, specific gravity and osmolarity. This is the main normal response. Activation of RAS and the CNS, sympathetic nervous system, and activation of antidiuretic hormone. Labs just guide you to volume depletion. You examine your patient and you are hesitant, is depleted or euvolemic. Just suppose look for hematocrit. You will find hematocrit is high, urea is high, bicarb is high from contraction alkalosis, and urine specific gravity will be high, and urine osmolarity also more than 500, and the urine sodium less than 10 to 20. And this also passive reabsorption of solute down, their concentration gradient, urea, calcium, and the potassium proximal convoluted tubule. Urea is filtered into the proximal tubules initially at low concentration, small font, but sodium reabsorbed as usual here. As usual with the water via this aquaporine. Urea concentration will be rise here towards the end of the tubule, and will be greater concentration gradient reabsorption from the lumen to the blood. The concentration will be increased, will increase here. This will lead to more urea in patients with hypovolume depletion. Just to be easy for what is this fraction excretion, whatever you like to calculate, sodium, potassium, calcium, phosphorus, magnesium, whatever you like. This fraction excretion is urine. This equal urine multiplied by plasma urine. You will start by urine just to do Excel like that. Urine sodium multiplied by plasma creatinine على الurine على البلازما sodium multiplied by urine creatinine multiplied by 100. If less than 1, this pre-renal. If less than 35%, this pre-renal. Just don't forget this fraction excretion if not on diuretic. This even on diuretic if less than 35, this with pre-renal. Again, this patient had blood pressure hypotensive, can't stand, little bit tachycardia, when standing, GVB is flat, negative bladder scan, urea 35, hematocrit 35, urine sodium is 11, means hypovolemic. We restore here with normal saline, and we DC all nephrotoxic ACE and steroidal adjust any drug medication for antibiotic. What is else for renal GIT loss, nausea, vomiting, diuretic, and low cardiac output, heart beat, occasion shock with the no, and sepsis already. We suspect that. We send the whole workup for that. Or patient already started antibiotic. And renal, any other causes for renal vasoconstriction, drugs, calcineurin, non-steroidal, already non-steroidal, and the contrast, amphotericin, hypercalcemia, hepatorenal syndrome, and different arterial vasodilation, ASRR. Perirenal means decrease actual effective arterial blood volume. 70% community acquired AKI, 40% in hospital. Reversible with correction causative factor characterized by bland urine sediment and the fraction excretion sodium less than 1. Our just from this slide, just this cortex and outer medulla, inner medulla, our blood flow, renal blood flow around 1,200 ml per minute, and around cardiac output around 20 to 25% of the cardiac output. Did our renal blood supply or perfusion, majority goes to the cortex, and the medulla responsible for concentration of urine, high ATP consumption. Just this number just to remind you, and this tubuloglomerular feedback here, this part from distal tubule and the macula densa, this is macula densa, and then the afferent arterioles. And when you have this our tubules here, tubular damage already, the chloride will come here and sodium, just will send signals to stimulate adenosine from this macula densa or from afferent cells. This will lead to afferent vasoconstriction and more decrease glomerular capillary pressure and decrease net apoptosis. All this will decrease the GFR. With this vasoconstriction, decrease the blood flow from this juxtaglomerular apparatus in patient with hypovolemia. Perirenal either decrease extra when you assess the volume, either low volume or high volume, extracellular volume. If low volume means renal loss, surface space, GIT loss, hemorrhage. If with extra hyperluxation, hypervolemia, extracellular fluid, either low cardiac output, patient was congestive heart failure is the most common example. And here, if systemic arterial vasodilation, cirrhosis, sepsis. Patients with liver cirrhosis, sepsis, and medication, autonomic neuropathy, whatever. Case, second or third case, 51 years old man admitted with gram-negative urosepsis in the ICU, hypotension, 70/40. He received normal saline cephalosporin, creatinine is rising, and the blood urine output is decreasing. What is the key test? What is the key test for this patient? If you have this patient referred for you, 51 gram-negative urosepsis, blood pressure 70/40, and the normal saline cephalosporin, and the creatinine start to be rise and the urine output start to be decrease. What is the key test for this patient? Just urine. Just look for urine under microscope. Okay. We'll see urine. We see multinucleated cells. This is white blood cells. If you don't see before, this is the white blood cells with multinucleated cells. You will see many cells here. You diagnose this patient maybe interstitial nephritis, maybe UTI. You don't know. This is a hyaline cast, normal cast. This is granular cast also. And with multinucleated cells, multinucleated on this hyaline cast, this means white blood cell cast here. This is white blood cell cast with white blood cells with multiple cast. Also, this is multinucleated cells, many nucleus inside the cells. This means white blood cells, and this means white blood cell cast. Here, only one here, one cell here. I need to show you. This is red blood cells double contour, but this cells with lipid nucleated nuclei. This is white blood cell. The white blood cell cast is clear here already. Binucleated, multinucleated cells. This with a white blood cell cast. This is also white blood cell cast. And this heme granular cast, muddy brown cast for picture. This is the hallmark picture of ATN. This is muddy brown cast or heme granular cast. Question: does this patient have ATN? What is the key test? Urine. What is the cause of ATN? What is how we can treat? What is the complication? We'll see. AKI, either perirenal, renal, postrenal, and the renal, either vascular, glomerular, tubular interstitial, ATN, interstitial nephritis, diffuse tubular obstruction. Diffuse tubular obstruction, don't forget either drugs, doing this crystals, uric acid, and light chains, either acute tubular necrosis, either ischemic or toxic exogenous, endogenous rhabdomyolysis, intravascular hemolysis. Interstitial nephritis, either drugs, autoimmune infection, and the cancer. What is acute tubular necrosis? As we discussed before, I give you a baseline to understand this now. This is a widespread injury and often death of renal tubular cells due to significant injury, ischemia, and reperfusion, either ischemic 18 or toxic 18. Cells will be damaged and sloughed from the tubular basement membrane and lead to occlusion of the tubular lumen, diffuse tubular obstruction due to sloughed epithelial cells, back leak, as we mentioned before, 18, damage epithelial barrier, filter the serum across the damaged epithelial barrier from the tubular lumen and or return it to the circulation. It is as if the solute had never been filtered in the first place. TGF already 18 decreases tubular function, decreases absorption of chloride to macula dense, adenosine signals to afferent arterial vasoconstriction, and decreases GFR. I think that clear. Tubular interstitial nephritis either 18 ischemic or toxic as endogenous, exogenous, rhabdomyolysis, intravascular hemolysis is endogenous. Drugs that cause tubular interstitial nephritis, antimicrobial, any antibiotics can do. Antineoplastic, any anti-cancer can do interstitial nephritis. Contrast dye, zoledronate, and hyperosmotic sucrose, immunoglobulins, mannitol, immunoglobulin, mannitol, dextran, and drugs like cannabinol and vitamin. What is the treatment of 18? Just observe. Conservative management. Avoid your patient to be volume depleted or volume overload. To be wise in your management. Stop any nephrotoxic non-steroidal. Stop any, avoid any contrast. Dose adjustment, medication, nutrition, and treat any complication, dialyze. Plan for your dialysis. This is any treatment for ATM, volume assessment, volume adjustment, stop non-steroidal and contrast, adjust any dose, medication, nutrition, treat complication, dialyze the patient whatever he need. What is your indication for dialysis? Don't forget uremia, and put under uremia three indication: uremic encephalopathy, uremic pericarditis, and uremic bleeding tendency. Either refractory fluid or electrolyte, pulmonary edema refractory to diuretic, hyperkalemia refractory to antihyperkalemic, metabolic acidosis refractory to bicarb infusion. Dialysis modalities are whatever available, but if the patient hemodynamic and unstable, please just use CRRT, don't use SLED. Just don't forget the temporal line or tunnel line according to the facility available in your center. What is your outcome? Mortality around 40 to 60% in the ICU patient, 40 to 60% mortality. Renal outcome, some patient will be fully recovered, some will end by CKD, some will be dialysis dependent. And with another case, this is a fourth case now. I have in this presentation more than 15 cases, and all you will meet in your practice in nephrology. This patient around 60, 70 years, male patient, COPD, hypertension, BPH, diabetes type 2, metformin, perindopril, metformin number 1, perindopril, indapamide, pyrevia, presented by short breath, fever, cough. This is a picture of infection, hypotension, desatting in 4 liter with respiratory distress, with a little bit leukocytosis and a little bit anemia. His AKI already, his creatinine baseline around 65 or 70. He presented by this highlighted AKI 210 with metabolic acidosis and hyperkalemia and lactic acidosis also. All this with septicemia or septic shock or septic shock. Deteriorated in ER and intubated, shifted to ICU. What is the differential diagnosis for your AKI? What is the investigation? Folic acid urine analysis. Don't forget what is the differentiation pre-renal, renal, post-renal. Investigation, please don't forget folic acid urine analysis, urine electrolytes, and ultrasound kidneys, and the management for your patient. If it pre-renal versus intra-renal, we'll see it doesn't matter. Very important practical distinction. Pre-renal AKI can be a risk, but if you'll give fluid and the patient improves, this means you are with pre-renal. If the intra-renal, the patient will not improve with the IV fluid. If any renal cause, which fluid are the best, colloid or versus cholesterol, balanced versus normal saline, IV sodium bicarb? I think at the end, this is big debates and confliction about the fluid. But you can use whatever available, balanced, I think is okay, or normal saline, but normal saline just will deteriorate more your acidosis. I think is the best solution to start for any patient like that, just isotonic bicarb. I told you before what means by isotonic bicarb. This is around 850. Don't forget 1 liter D5 water. 1 liter D5 water. I will take 150 from this 1 liter D5 water and I will put 150 millimole sodium bicarb on this remaining 1 liter. Now you have 1 liter isotonic bicarb and whatever rate you like as the patient tolerated and his echo function and the cardiac function for him. No difference between colloids. Colloids means الالبومين. No difference between colloids and the crystalloids. Starch طبعا increase the AKI albumin, higher mortality, especially in patients with traumatic brain injury. Two recent trials already published in National Journal already in 2018. One in critically ill SMART and one on non-critically ill assaulted patient. No difference in mortality, less AKI, but no difference in renal replacement therapy between the colloid and the crystalloid. Bicarb ICU benefit to treating critically ill patient with severe metabolic acidosis. We have benefit already if the patient receive isotonic bicarb by this bicarb ICU trials. Okay. Sodium bicarb given, isotonic bicarb given, 3 ampoules. As I mentioned for you, 3 ampoules because each ampoule 50 ml, 150 to 850 D5 water. And infusion 100 ml per hour, whatever, 70 ml per hour, 100, 150 ml per hour. No urine output with folic acid insertion already. And I check the folic acid, no, not blocked, no, and the brother not distended. And the friction excretion sodium already 1.8 from this our equation I discussed before. This picture not with pre-renal, this renal now, not less than 1, this more than 1. And the urine osmolarity around 350, not more than 500, this with renal cause. And the urine sodium is high, not less than 20, not with pre-renal, this not with pre-renal, this not with pre-renal. And that all picture with renal cause, okay? And this urine microscopy, we found heme, granular cast, muddy brown cast. Don't forget this cast. If you have microscope in your place or in your hospital, you will take just urine sample, centrifugate, and you look under microscope, you will see this clearly. And this clear, I take by myself this for one patient. I already discussed this patient in GN, AKI clinic, in AKI presentation before. If you like to hear, you will enjoy by this case. And this clear heme granular cast, muddy brown cast, picture a hallmark of ATN. Acute tubular necrosis either from antibiotic metformin is diuretic. All this will be held for our patient. Low potassium diet, oxygen ventilator requirement worsen, still oliguric and uric, creatinine 350, potassium 60.2. What you will do next is our patient. Our patient diagnosed now by this urine is ATN. It will take time. It will take days, weeks, months to be recovered. Patient received, this patient already received antibiotic and the patient with metformin is diuretic. All this will be held. Any patient with AKI, you should check medication and held whatever. Any medication will deteriorate his condition. Metformin will increase lactic acidosis. Better to stop already and release and the diuretic knows the time now to use this medication. Strict low potassium diet, oxygen increased, oliguric increased, creatinine increased, potassium increased. What is next for this patient? Furosemide for volume overload and hyperkalemia. You know, furosemide will help that, will excrete more. And potassium, you know, any patient, I already put in our channel, my channel, nice presentation for hyperkalemia. If you listen, you will not forget in your life. Just for this furosemide, just one method for management of hyperkalemia by excretion in urine. You can go for stress dose. You know what is stress dose? 1 milligram per kg if your patient naive means not received Lasix before, or 1.5 milligram per kg if your patient non-naive, he received Lasix before, okay? This is stress dose, okay? And you will see urine output within the next 2 hours. If less than 200 means your patient is renal etiology. When to dialyze, indication of dialysis, as I mentioned before, refractory acidosis, refractory hyperkalemia, poisoning intoxication, refractory fluid overload after stress dose, uremia, pericarditis, encephalopathy, anticipatory of aneuric to get central access earlier. The indication, don't forget uremia, encephalopathy, pericarditis, bleeding tendency, refractory fluid pulmonary edema, refractory hyperkalemia, acidosis. Early versus late, and all studies even start AKI, last one, large multi-center randomized, no benefit for too early start dialysis as regarding mortality and the hospital stay, whatever. Option for renal replacement, whatever available with you, can use the conventional regular machine as a sled order for 8 hours at least. With blood flow, as I mentioned, I put already presentation for a CRRT in my channel, CRRT, and the sled order in details to prescribe safely without asking anyone, and by all details. either slid if no CRRT machine available, but better to use CRRT machine. I discuss all this modality of dialysis for hemodynamic unstable patient in two presentations, one for CRRT and one for slid and regular dialysis. And if you like to hear, you will not you will not ask anyone after that. No evidence either is superior, either slid or CRRT, and the best mode to use hemodialysis and filtration hemodialysis and filtration in one mode, CVV HDF is the best mode to use in dialysis, especially when you are using CRRT. Resolution, our patient already recovered after received this but start to be got urine output, and we gave it Lasix 160, urine output 50 to 100, start to be Lasix infusion, and after that only one studies, no difference between Lasix infusion and boluses, but my experience Lasix infusion better than the boluses, because the Lasix infusion just keep your blood pressure stable, and if you will go by 5 or 10 milligram per hour, you can increase to 50 milligram per hour, 20 milligram will give better response. If your patient respond, will be respond. And metalazone, just we can add as a synergy to just enhance the effect of Lasix by blocking the sodium chloride co-transporter in the distal convoluted tubules, decrease the sodium reabsorption. This will enhance the Lasix activity, and the creatinine improves, and the Lasix less than 5 by this Lasix infusion. After that, the patient start to be polyuric after giving this Lasix, 2 to 4 liters per day, a phenomenon of polyuria, increased sodium, tubular damage, madar rewash. We need to, most of solid content in urine near half normal saline, you can replace by 75, 1 to 1, maybe 1 day, or 1 to 2, and 75 decrease. Just if the patient bring 1 liter, you can give him only 700. If he second day, if you will give 100, you can give him 50 ml. His third day, if you will give 100, just to give 25 or 30 ml, and then stop replacement by day 4 to give the kidney chance to adapt, reabsorb, and adapt to concentrate urine by herself. Okay, don't give more fluid, give a chance the kidney to work and the tubules to regenerate rapidly. Okay, just to follow this protocol. If you have patient with polyuria, in D1 just replace by 75% of the urine output by half normal saline. Day 2 just replace by 50%. Day 3 25% half normal saline. Then day 4 stop replacement. We'll go now to intrinsic renal disease or renal disease most common in hospital and ICU, AKI, sepsis, infection, malignancy, whatever, and the drugs already. This is the most common cause of intrinsic, classified according to anatomical location of the kidney. Either the renal cause of AKI, either vascular, cholesterol imply after any cardiac cast or cardiac surgery, renal vein thrombosis, and others. GN, either acute GN, hemolytic, interstitial, acute interstitial drugs, infection, myeloma, and tubular disease, ischemic, nephrotoxic, and septic ATN. And the broad differential diagnosis of our renal, either vascular, glomerular, tubular, interstitial, acute tubular necrosis, interstitial nephritis, and diffuse tubular obstruction, we discussed before. ATN responsible for most of the cases of hospital-acquired AKI, commonly occurs in setting of sepsis, cardiovascular surgery, severe burn, pancreatitis, chronic liver disease, almost always multifactorial, impaired renal perfusion, impaired autoregulation, and sepsis, nephrotoxination. Maybe oliguric, non-oliguric, typical course and complicated disease recovery during 2 to 3 weeks. Take care from that. This is responsible for most cases of hospital-acquired AKI. This occurs in sepsis, cardiovascular surgery, burn, pancreatitis, chronic liver disease. This is a common picture of ATN. Workup, just exposure of renal associated with ATN, either just to control hypotension, surgery, check for blood loss, large blood loss, transfusion reaction, contrast dye, symptoms and signs of intravascular depletion, replace that, or hypervolemia, evidence of obstruction, please ultrasound and folic acid, evidence of cause of acute rash, fever, maybe acute interstitial nephritis, rash, fever, non-patient and antibiotic acute interstitial nephritis, you should put in your mind, okay? Urine analysis, you should, this is the gold standard for us after kidney biopsy, before the kidney biopsy, that microscopic examination, the mistake microscopic as we mentioned before, and the picture you choose the type red blood cells, white blood cells, and the epithelial cells, broadcast, highline cast, Hingerer cast, muddy brown cast, whatever. The best surrogate of histological state of the kidney, available, rapid and expensive test. Just you can see if you have microscope, I am sure you will learn that rapidly is not so so difficult. Just you will take your sample, centrifugate, and after that you will take the precipitate from the bottom of the tube and you will put on a slide just one drop only from this الراسب اللي بيبقى في قعر الانبوبه ده، وتحطه على الشريحه وتشوف تحت الميكروسكوب وتغير العدسات بتاعتك. مع الوقت تتعلم، يعني ممكن اسبوع بالكثير تعرف كل الحاجات دي. الموضوع مش ديفيكالت، والمفروض في العيادات يكون موجود مايكروسكوب معاك مع الترا ساوند طبعا كنفرولوجيست. دي سكوما السيل ده المنظر بتاعها، وده ترانزيشنال اللي بيصير كل دي المنظر الخلايا الملعبكه ديت على طول تبقى ديت سكوما سيل. هنا رينال تيوبر ريبسيل سيلز نفس الكلام برضه. لسه عارفها حاجه الهيلان كاست معليك منها، دي جرانيولار كاست عاديه ما فيها شيء. هنا ديت ريتيكولوسايد واكسي كاست اند ديس فاتي كاست، هتلاقيها وايت، هتلاقيها وايت ولميعه كده. هنا ريد بلاد سيل كاست اللي هي دبل كونتورز، الخلايا بتاعت الريد بلاد سيلز دبل كونتور، وهوريها لك برضه. وده وايت بلاد سيل كاست المالتي نيوكليتد احنا شفناها، دي وايت بلاد سيلز هي مالتي نيوكليتد. ايوه دي ريد بلاد سيلز اللي هي دبل كونتور، ولو لقيتها على كاست كده تبقى دي ريد بلاد سيل كاست. تمام. ودي ديسمورفيك ريد بلاد سيلز تلاقيها كده عامله ديت خليه وتلاقي عليها ايه حتتين مكسرين او راسين كده وحاجات غريبه كده، الميكي بوي ولا انا فاكر كانوا بيسموها ايه. المهم تلاقي ديسمورفيك مالتيبل ديسمورفيك شيب اوف ذيس دبل بلاد كونتور، دبل وول كونتور في ريد بلاد سيلز. دي اوضح شويه، ده دي بسيل السيل عاديه خالص نفس الكلام. ودي برضو سيلز على الكاست، دي اسمها ريتيكولوسايتس على كاست، دي ريد بلاد سيل كاست مش واضحه برضه، دبل كونتورز كده على الكاست، دي ريد بلاد سيل كاست. دي ثايلاين كاست بتلاقي كده من غير شيء. دي المادي براون، دي هيم جرانيولار كاست كلير، لو انت شفتها مره ما تنساها مره. دي اندينافير، وديت الكريستالز اللي ساعات بتشوفها برضه بتشوفها مع السيلينج لايكر والحاجات دي. النقطة دي احنا قلناها ازاي تفرق البريرينال والبوسترينال، وان اليورين اسمولاريتي مور ذان 500 في البريرينال يورين صوديوم and fraction excretion less than 1. وهنا الفرق في ال ATN طبعا بتشوف الهيم جرانيولار كاست الثاني والشوفس، ده النورمال كدني ودي الكورتكس وده المضله، وما فيش عندنا هيدروفروز ولا شيء، والكورتكس جميله والكدني زي الفل. هنا طبعا ده سيفير هيدرونفروزس، طبعا المضله رسيننج هنا وكل ده هيدرونفروزس. ايه هي الكومبليكيشن بتاعت اي كي انت خايف منها؟ فوليوم اوفرلود، تيك كير فروم ذات، ديلي اسسمنت فور ذات. الكترولايت خاصه الهايبركاليميا والميتابوليك اسيدوزس واليوريميا والانفكشن والجي اي تي بليدنج. sepsis associated with AKI. This is the long syndrome already in ICU. Sepsis ده life-threatening organ dysfunction is a life-threatening organ dysfunction caused by this circulation host response to infection. Organ dysfunction can be identified by an acute change in the total اللي هو organ assessment daily score, sequential organ failure assessment, sequential organ failure assessment score more than 2 points consequent to the infection. With organ dysfunction identified as acute change in the total sequential organ failure assessment score more than 2 points consequent to an infection. This sepsis AKI. Sepsis is the most common important cause of AKI in ICU, mostly abdominal infection, responsible for 50% in the AKI in critically ill patient. 15 to 20% of septic AKI patients are prescribed renal replacement therapy associated with high risk of short or long-term mortality, longer duration hospitalization, later development CKD and renal disease. Pathophysiological theories, early experimental studies of septic AKI suggest decline in renal blood flow. More recent study of hemodynamic sepsis demonstrates septic AKI develop in presence of high renal blood flow. Despite this increased renal blood flow, ischemia maybe still occurs. Regional distribution of blood flow implies activation in intrarenal shunting pathway. This just rapid for the pathogenesis is just related to inflammation, micro-inflammation and microvascular circulatory dysfunction and metabolic repositioning, interstitial edema, and the increase in auto diffusion. All this activation, this inflammatory cascade within the tubules leading at the end ended by apoptosis and necrosis and epithelial cell damage, and lead to the same issue for acute tubular necrosis as we discussed before. We'll go now to cardiorenal syndrome, acute decompensated heart failure, acute decompensated cardiorenal syndrome. Just this is because this cardiorenal is will start by the heart, is the first, our main pump in our body. Because this cardiorenal will start, is two types of cardiorenal syndrome. We have 5 types already. 2 types: acute heart failure lead to acute kidney injury, chronic heart failure, chronic kidney injury, and the type 3 acute kidney injury lead to acute heart failure, and the chronic kidney injury acute chronic heart failure. Type 5 systemic condition, sepsis, heart and kidney dysfunction, both like sepsis or vasculitis, whatever. Yeah, this is the type 5 types for cardiorenal, and I suppose I will give one presentation for separate for cardiorenal. Just I give a hint to cover all AKI today. What is cardiorenal syndrome? The cause of AKI or CKD, cardiorenal means primary cardiac problem, decreased GFR. This is type 1 acute or type 2 chronic cardiorenal syndrome. I need you to understand this slide for mechanism of cardiorenal syndrome until we discuss this in separate presentation. In heart failure, decreased cardiac output means decreased blood pressure, means activation of vasoconstriction, sympathetic RAS, and diuretic hormone, means decrease renal blood flow, means decrease GFR. And also increase the right side filling pressure, renal venous congestion, renal interstitial edema, and lead to intratubular pressure, and decrease the pressure gradient in renal artery and renal vein. All this decrease the renal blood flow and lead to decrease the GFR. This is a mechanism either by decreasing cardiac output, hypovolemia, ended by decreasing renal blood flow, decreasing GFR, or either from renal venous congestion from right side filling pressure, lead to renal interstitial edema, increase in intratubular pressure. All this will lead to decreasing GFR. This is a mechanism of cardiorenal syndrome, either from decreased cardiac output, hypovolemia, and activation of vasoconstrictor, or right side filling pressure, renal venous congestion, renal interstitial edema lead to increase in intratubular pressure, decrease GFR, or decrease the pressure gradient in the renal artery to renal vein, decrease the renal blood flow, decrease GFR. This is a sample of any mechanism for cardiorenal syndrome. Don't forget this algorithm for cardiorenal syndrome is easy to understand any cardiorenal syndrome. Renal venous congestion, as we mentioned before, and there to decrease the right ventricular overload. Dose the trial, diuretic optimization trial, comparison high dose versus low dose, continuous infusion versus boluses. قصص كده يعني all the end is equivalent to both continuous or bolus is equivalent, no significant difference. Ultrafiltration with the patient with refractory to our diuretic. Better to sink in ultrafiltration this patient, but recovery, kidney recovery with the diuretic better than the patient with ultrafiltration group will be more deteriorating kidney function and delay in recovery. Okay, take care. Take this process in your mind. We'll go to one case of cardiorenal, 70 years, coronary artery disease, diabetes, CKD, congestive heart failure, ischemic cardiomyopathy, on aspirin, Concor, and the P, telmisartan 80s, furosemide 80s, insulin, blood pressure 88, GVB6 is elevated, and the crackles bilateral until mid-lung zone, beating ankle edema, creatinine to 7.5, 2 weeks ago 130, creatinine increased from 130 to 7.5, you're on about 20 cc per hour. Urine bland, urine lysis, low sodium, potassium, urine osmolarity 470. Just about in your mind, our patient here is cold and wet, because why cold and wet is hypotensive and congested. Hypotensive, congested should be wet and cold. This warm and dry, this patient sepsis is the first patient. If you like, any patient congested, just you need to know or yes. If no, this warm and dry means septic, cold and dry means this patient just hypovolemia. If yes, warm and wet and cold and wet means this patient hypovolemia, maybe sepsis with volume overload, but this patient, our patient now cold and wet, hypervolemia with hypotension, and then the pathophysiology we discussed before, cardiorenal, and with by decreasing cardiac output and increases sympathetic and increase the venous congestion. All this we discussed already before. and this will end by vasoconstriction and decrease the perfusion pressure, increase the venous pressure, and all this lead to venous congestion and decrease at the end, increase the interglomerular pressure, and this will end by decrease the GFR. If you will have time, just look for it, and I prescribe that description before. Furosemide high dose given 120 for this patient. Patient started to urinate around and lost 1 kg per day. Blood pressure start to improve. Creatinine start to improve. Creatinine 140 micromole. Typically of cardiorenal syndrome type 1. If the patient is responding to diuretic and his body weight already decreases our target, and the blood pressure start to be improved and the creatinine start to be improved. This is the typical picture of cardiorenal syndrome type 1. If no response to diuretic, control vasopressin intravenous nitrate may be required. Another case, a 40-year-old man, previously well, admitted with jaundice, ascites, creatinine 120. I think we'll go now to hepatorenal syndrome case. Jaundice, ascites, creatinine 120, bilirubin 420, bilirubin nephropathy. Oh, we will go to cast nephropathy. LTST is elevated liver biopsy, alcoholic hepatitis with cirrhosis, serum creatine progressively rose to 800 ton. Oh my God. Despite IV normal saline, albumin blood transfusion, urine analysis, few yellow cast. This is bilirubin cast. And urine already less than 10. What are the hemodynamic consequences of cirrhosis? Systemic vasodilatation, splank vasodilatation. Splanking vasodilatation from nitric oxide and bacterial product not cleared by the liver. All this lead to vasodilatation. This is the hemodynamically instability in cirrhotic patient from systemic vasodilatation. Splanking, vasodilatation, nitric oxide, bacterial product not cleared by liver. Intense intrarenal vasoconstriction from hypovolemia already. From this splank vasodilatation lead to decreased perfusion and hypovolemia and the sympathetic nervous system stimulation and RAS stimulation triggered by systemic hypotension and endothelin. This lead to intense intrarenal vasoconstriction. This is the mechanism of AKI. And the autopsy after, this our hepatorenal is functional, not renal problem or like that. This already perfusion here, this autopsy kidney after the patient died already, and just injecting contrast angiograph already showing good perfusion to kidney. This means we are functionally not renal problem. The type 1 hepatorenal syndrome, our case, a very poor prognosis without liver transplant. Treatment albumin for intravascular volume expansion. We'll try to give albumin, vasoconstrictor, isomidodrine, the alpha antagonist for systemic vasoconstriction. Any patient with hepatorenal syndrome, albumin. You can give TID per day, whatever available with you. TID albumin, midodrine, we can give 10 to 15 to 20 to 30 milligram TID per day. Ectorotide, we can give 100 subcutaneous TID per day. Just don't forget MAO, M-O-A, MAO for hepatorenal syndrome, MAO. Midodrine, ectorotide, albumin. Midodrine, ectorotide, any patient with hepatorenal syndrome. And stop in nephrotoxic and diuretic, and we'll see. Terlipressin, this I don't know, anyone used this before, but already I am adapted with MAO regime, and if the patient will improve. Otherwise, your patient maybe you need dialysis or kidney transplant. And the issue for dialysis to bridge for liver transplant or no. This according to country and the facility and the family agree or no. This decision should be done. But dialysis will not improve the outcome or prognosis of your patient. Should discuss this in details with their family, and we can discuss this later, how you can deal with hepatorenal syndrome and the family and the patient in bad condition, hematemesis, hepatic encephalopathy, and with AKI not recovered, with hyperkalemia, autoleucoacidosis, and family insists to dialyze. How you can discuss this? We'll discuss this later. Tips is one just for treatment this cirrhosis and ascites. And the liver transplant, this is a definitive treatment for hepatorenal syndrome. And this is the tips mechanism we can discuss later in separate presentation. Our hepatorenal disease is pre-renal from systemic vasodilatation, either from sepsis, cirrhosis, anaphylaxis, like that. Another case, I think this is a 6 or 7 case. This 72 years male patient, alcohol, smoking, obese, diabetic. Tamam. Patient presented with abdominal distension, peripheral edema, nausea, ultrasound shows cirrhosis and ascites. Liver enzyme is high, GGT is high, admitted to hospital for workup and diuresis. furosemide and spironolactone. They too had increased pain and fever. Increased abdominal pain and fever, okay? This patient already alcoholic, cirrhosis and ascites, and with abdominal distension, peripheral edema, and nausea like that, and with abdominal pain, spontaneous bacterial peritonitis, because any patient abdominal pain and fever, did the SBP until proof otherwise, became mildly encephalopathic, and started the lactulose, day 3 creatinine from 82 to 146, okay? Hepatorenal syndrome, as you know, the diagnosis of seclusion. Hepatorenal syndrome, a form of kidney function impairment that characterized by that occurs in cirrhosis. This is a form of AKI just occurs in cirrhosis. Recent terminology: acute kidney injury hepatorenal syndrome and CKD hepatorenal syndrome. AKI hepatorenal syndrome, AKI hepatorenal syndrome, severe impairment of the kidney function due to vasoconstriction of renal arteries, as we mentioned before, in the absence of substantial abnormality in the kidney histology. Okay. I need you just take a picture for this slide to understand what is the pathogenesis of hepatorenal syndrome. The theoretic liver, theoretic maybe lead to theoretic cardiomyopathy and decreased cardiac output, and this will end by, you know, here the easy mechanism for pathogenesis of hepatorenal syndrome. That you should have portal hypertension, and this portal hypertension with the vasodilator material leads to splenic vasodilatation, decrease the vasculature, and decrease. And will decrease the effective arterial blood volume, and this lead to activation. All this lead to renal vasoconstriction, decreased GFR. And cirrhotic also cardiomyopathy, complication with liver cirrhosis, decreased cardiac output, same scenario. And bacterial also lead to vasodilatation, also same scenario. Easy pathogenesis for hepatorenal syndrome will not take 1 minute from you. If you read from book, you will be confused like that. It's easy to take from here. And it's the same here, hepatorenal syndrome, cirrhotic liver, obstruction of we should be have portal hypertension for splenic vasodilatation, and same scenario. And the bacterial infection, same scenario. And the toxin vasodilatation, all same scenario. Hypotension and the stimulation of the nervous system and the sympathetic nervous system. And with all same scenario will end by the AKI hepatorenal syndrome. Criteria, as we mentioned, the classical diagnostic criteria for hepatorenal syndrome you can read, and with new diagnostic criteria for AKI is hepatorenal syndrome, cirrhotic with ascites, diagnose AKI as the criteria before not respond to consecutive, and we'll summarize here. Any patient should be cirrhosis ascites, serum creatinine increase more than 133 micromole, no improvement in serum creatinine after at least 2 days of diuretic withdrawal and volume expansion with albumin. The recommended albumin 1 gram per kg body weight per day up to maximum 100 gram per day. Absence shock, no shock, no current recent treatment of toxic medication, absence of parenchymal renal disease, no proteinuria more than 500, no red blood cells more than 50, and no abnormal finding in ultrasound. This criteria just put in your mobile if you will face any consultation for patients with hepatorenal syndrome. Hepatorenal syndrome outcome, prevention, early identification, treatment of bacterial infection plus albumin in patients with SCBP will improve your prognosis or at least the recovery from AKI. Prognosis. Prognosis poor, median survival. This is a fire alarm, sorry for that. Prognosis is poor and median survival of less than 3 months. Poor median survival for this type 1 and less than 3 months. But الأعمار بيد الله ممكن المريض يعيش معك يعني كنت تموت قبله يعني. Ideal treatment liver transplant, ideal treatment or definitive treatment for this hepatorenal syndrome liver transplant. Medical management, as I told you, don't forget MAO, midodrine, octreotide albumin. Don't concentrate. Yeah, I put here already MAO. Don't forget this regimen for any hepatorenal syndrome. Treat extent of the creatinine rise influences the chance of reversal. Treat the precipitating cause of just any precipitating cause for hepatorenal. You can treat. Stop like diuretic, sepsis. Stop diuretic. Volume expansion with albumin. Vasoconstriction, as we mentioned, MAO. Tips also dialysis. only the bridging for سيرب bridging سيرب. لو العيان اللي عنده بلان لترانسبلانت معلش ده الوحيد اللي ممكن تعمل له dialysis. غير كده ممكن تعمل full discussion with the family, no benefit from dialysis will not improve the prognosis, maybe will deteriorate him during the dialysis, and hypotension, encephalopathy after dialysis, electrolyte disturbance will affect his lifestyle better than if he's without dialysis. Reversible AKI 83% after liver transplant, يعني around 80 more than 80%. Liver kidney transplant consider patient dialysis more than 8 to 12 weeks. 8 to 12 weeks. لو العين بتاعك 8 to 12 weeks on dialysis, better to do liver and kidney transplant, wait and see if no plan for transplant. A case, another case, I think 8 or 9. The 45 years male patient with cocaine abuse, weight loss, cachexia, abdominal pain, nausea, felt unwell, and he had not decreased urine output for 1 week. Your patient, 45 years, male, cocaine abuse, abdominal pain, nausea, decreased urine output for 2 days, creatinine emerge 1000, potassium 5, bicarb 16. Creatinine 1000 from normal, and the potassium 5, bicarb 16, no other systemic symptoms, urine plan, and you fully catheter inserted, minimal urine output, ultrasound, mild bilateral hydronephrosis. Take care. This patient cocaine abuse, they became abdominal pain, nausea, decreased urine output for 1 week, no urine output for 2 days, no urine output, obstruction till prove otherwise. Okay, and the creatinine 1000 from normal is horrible. I think with folic acid, the minimal urine output, ultrasound, mild bilateral, because the patient don't ما تتخدعش بالمنظر ده، لان انت اول ما تدي فلويد عين ده ممكن الهيدروفروز يبان معاك. السي تي ريزلت bilateral obstructive stones, bilateral obstructing stones. Urology took him to OR after CT and the scan. Resulting came out overnight. The patient got bilateral ureteric stent. Bilateral ureteric stent. AKI for expertise. Rule out obstruction. Folic acid is not enough. Rule out obstruction. Folic acid not enough. Take care from this case. All hydro is significant. It may be false negative if the patient is intravascular volume depleted. Okay. Cause of obstruction, as we mentioned before, BPH, stones, trauma, tumor, restriction, neurogenic bladder, UTI, medication, anticholinergic. All this causes of urinary tract obstruction. Where it gets tricky, retroperitoneal fibrosis, malignancy, autoimmune, IG4-related disease, radiation, drugs. You need a high degree of suspicion. You need a high degree of suspicion. Maybe this obstructive fibrosis, and then it's CT or MRI with better without contrast. We are using CT without contrast for this patient. Don't look for laser. Okay. Another case, 65 years of female, minimal past medical history, not feeling well for 3 months, cough of blood yesterday and today, coughing blood with hemoptysis. Okay, 2 days now. Blood pressure is hypertensive with lower lymphedema. Creatinine is high. 6 months is normal. AKI 250 from 60. And protein of blood, I think this patient picture of a GN, microscopy, red blood cells, a few cast containing red blood cells, chest X-ray, cavitary lesion, left lower limb. Just trust me, to be honest with you, this is the first time I read this slide with you, because just I am preparing my presentation, because I take long time to prepare, I think 1 week, and I am reading with you. I just write all this, but I just writing, I'm not concentrate too much on during the writing, because sometimes I'm busy in my work also. Just as the first time I read this slide with you, this is a picture. You suspect this patient with RBGN. The patient coughing blood, you think is hemoptysis, pulmonary renal syndrome, with hypertension, edema, creatinine from normal, and this is 3 blood proteins, red blood cell cast, cavitary lesion in the left lower lung. This is RBGN, either anti-GBM complex position or ANCA-associated vasculitis. Key issue here, suggest AGN, pulmonary renal syndrome, need urgent workup for serology for GN, C3, C4, ANA, and double strand, CB, ANCA, and cryo, and hepatitis C, B, HIV, and the serum protein electrophoresis, serum free light chains, and urine immunoelectrofixation. Also, we need all this. And the kidney biopsy, prepare for kidney biopsy, likely need urgent immune suppressive therapy. Also, you can start pulse steroid if creatinine rising daily. 27 years, another case, 27 years old male, present with malaise, fever, nausea, rash. Malaise, fever, nausea, rash, abdominal pain, swelling. This is interstitial nephritis or what? Blood pressure is hypertension, chest is clear, peripheral edema, hemoglobin like that. little bit anemia, leukocytosis, creatinine 450, urine just 750. Anything else else in history, sexual, infectious, travel, drugs, we need all this. Or sexual history, infection, travel, drugs, family history, other constitutional autoimmune symptoms, investigation, management. With patient resistant, 27, young, male, malaise, fever, nausea, rash, abdominal pain, swelling, feet. Picture كده في systemic inflammation. That's sexual is young, male, infectious, travel, drugs, family history, other constitutional autoimmune symptom. Urine analysis shows this. I think this red blood cells, the double contour here. If you look for this, is a picture of red blood cells, and this the dysmorphic red blood cells, and you'll see. And this also we have here white blood cells, multinucleated. I think the multinucleated also. I think with multinucleated, but this red blood cells. What is tested to order just urine album? Yeah, we need to check the album urine ACR for this patient, urine album creatinine ratio, and the autoimmune liver as we mentioned for you, immunological workup all, and infectious workup, culture, hepatic serology, syphilis, parvovirus, B19, cryoglobulin, ANCA, anti-GBM, C3, C4, ANA, anti-double strand, serum electrophoresis, urine-free light chains, malignancy screen. Don't forget to rule out renal vein thrombosis for this patient. Diagnosis RBGN for this patient. Oh my God, this patient and the previous one. Oh, all this red blood cells is dysmorphic and this red blood cell cast. And all this picture of red blood cells double contours, not nucleated cells. Not nucleated cells like this. This is white blood cell cast, but this all not nucleated, this is red blood cells. Oh, this RBGN picture approach, lots of ways to break it down. Best way to begin to is by urine analysis. You look for urine analysis and interesting urine analysis and guide you to deal with your patient as emergency or no. Proliferative hematuria and dysmorphia and the cast formation of versus non-proliferative. After that, different people have different approach. Best is to keep it simple. Important thing is not being, don't miss the dangerous pathology entities. Having an approach help to ensure you order the right test, hopefully to be wise in your test, okay? And that approach a patient with glomerular hematuria, AKI, hypertension, subnephrotic proteinuria, either death, IgA, ANCA-vasculitis, and GBM, cryo, this primary or secondary ANCA-vasculitis, post-infectious lupus, myeloma, febris, hepatitis C, HIV. If with patient with nephrotic range proteinuria, edema, hypoalbuminemia, the non-proliferative, minimal change, membranous focal segmental amyloidosis type 1. I think all of us all know this. And this for active urine sediments, and the patient with nephritic and the nephrotic, and the differential diagnosis. The patient with nephritic RBGN, IgA, ANCA, anti-GBM, cryo, C3, Albert, fibrillary, and the secondary causes. RBGN, that's the differential diagnosis is immune complex, anti-GBM, boosting immune ANCA or anti-GBM or present complexes. This is just a picture if you like to read. Approach to IgN, just virology with this species HIV, anti-knee, anti-double strand, C3, C4, rheumatoid factor, cryo, protein electrophoresis, SPIP, and serum immune electrophoresis, serum free light chains, IgA, immunoglobulin pattern for serum protein electrophoresis, IgG, IgM, جامد اللي احنا قلناه في محاضرة الانكولوجي اللي قلناها الأولانية. CB, ANCA, anti-GBM also, this approach to any patient with GN. And the Bianca here positive for this patient, other workup all negative, and the normal glomerulus, and this patient was crescent also, crescentic RBGN, Bianca vasculitis. Started pulse steroid for 3 days, 1 gram for 3 days, followed 1 milligram per kg daily. Steroid sparing suppression, cyclophosphamide or rituximab. I think the patient started one for that, and plasmapheresis, trial pending, but our patient started already steroid and cyclophosphamide for that. This is practical approach before we continue. Practical approach to any patient with AKI. It's AKI. Creatinine طبعا by definition criteria more than 1.5 or more than 26 or urine output like that. Other criteria we mentioned in the first slide. Is the patient stable circulatory airway breathing? If yes, is the patient obstructed? If yes, fully caster and ultrasound. If yes, urology IR needing stenting or nephrostomy tubes. If not obstructive, acute indication for dialysis, as we mentioned before, shift diuretic IV bicarb dialysis. If an indication for dialysis as uremia or electrolyte refractory. If no indication for dialysis, either renal AKI, low renal perfusion secondary to intravascular depletion. If no, we'll go to other slide. If yes, extra vascular overload, congestive heart failure, total volume depletion, hepatorenal syndrome, IV albumin, hepatorenal protocol, congestive heart failure, diuretic, or cardiology. Total volume depletion give intravenous fluid. Now, if your patient already volume depleted, you will give fluid. If renal fraction sodium less than 1, low blood pressure, history of volume depletion. If this patient not pre-renal and this renal, intrarenal parenchymal insult, just urine microscopy, GN workup, CK for abdomyolysis, drug history, blood smear, and the protein to rule out all this differential diagnosis, ATN, interstitial nephritis, GN, TTB, HOS, cholesterol implied syndrome. Okay. Simply early management, stop nephrotoxin medication for inhibition of AKI, avoid any contrast, renally dose medication, potassium diet, EBO group screening, coagulation, INR, insert CVC if you think your patient need dialysis, try to achieve eovolemia. Okay, what is next case? 30 years old women. 30 years old woman previously willed 4-day postpartum with petechiae and malaise, drowsy and mild jaundice, creatinine around 195 micromole per liter, urine analysis +1 blood, +1 protein, no cast. What is the next test? 30 سنة, is young female, postpartum with petechiae, malaise, drowsy, mild jaundice, creatinine from normal 190 around 200. With positive protein, blood, and no cast. What's your differential diagnosis now? Postpartum with AKI and this picture, jaundice, protein or blood, and platelet is low, hemoglobin is low, and the LDH is high, bilirubin is high, mainly indirect bilirubin, and the fragments is picture of a TMA. TMA, multiple pathway, diffuse microvascular thrombosis. Take care from this case again. 30 years postpartum, is petechiae, mild jaundice, creatinine is high, all this finding is positive, pancytopenia, LDH is high, bilirubin is high, indirect, the hemophilia workup, hemolysis workup, all high. This TMA, multiple pathway, diffuse microvascular thrombosis, multiple, there is cancer, DIC, preeclampsia, scleroderma, this differential diagnosis, no thrombosis cause organ dysfunction, consumption of platelets, thrombocytopenia, destruction of red blood cells, bus thrombus, primary Shiga toxin diarrhea, or TTB also, or complement mediated TMA. We'll go here to this algorithm. Renal cause either vascular, glomerular, and renal vascular, either macrovascular, renal thrombosis, embolism, aortic dissection, or renal vein thrombosis, is artery and vein. Microvascular as a thrombotic microangiopathy, and this is differential diagnosis: primary, secondary, and drugs. Thrombotic micro primary, TTB, Shiga, complement mediated TMA. Secondary, cancer, infection, DIC, preeclampsia, severe hypertension, all this secondary cause. Primary, TTB, Shiga toxin, HOS, complement mediated TMA. Secondary, cancer, infection, DIC, preeclampsia, help, severe hypertension, scleroderma, transplant. Drugs, either antineoplastic drugs and cyclosporin, tacrolimus, drug abuse, cocaine, clopidogrel, anti-angiogenesis drugs, interferon, emitters, inhibitor. All these drugs lead to TMA also. Treatment of TMA, plasma exchange, first line of treatment, plasma exchange, plasmapheresis, corticosteroid, rituximab. We have plasmapheresis, the corticosteroid, rituximab. Typical HUS after diarrheal illness, the supportive care. Typical HUS, eculizumab, monoclonal antibodies, anti-C5, okay, a typical HUS. We have this main treatment for TTB, plasma, steroid, rituximab, typical supportive, typical eculizumab. Case 6, 22 years, female, and all these cases we'll discuss in detail in separate video. We have another case, 22 years, a female colleague student with diarrheal illness, comes with a decreased level of consciousness, fever, blood pressure, hypertension, creatinine 200. ERC and tells the nurse to start fluid and get lumbar puncture or try. He starts a broad spectrum high dose antibiotic for her. She is about to insert a needle when the nurse tells him, "Doc, look at CBC. This student came by diarrheal illness, fever, decreased level of consciousness, hypotension, AKI. And the doctor decided because this fever and rash here also, he started to plan to do lumbar puncture, but he found his platelet, her platelet around 6. This leukocytosis, hemoglobin, severe bicytopenia with leukocytosis, and the creatinine is high, little bit of stosis, potassium is okay. ACT, LT, alkaline phosphatase, amylase, lipase, bilirubin, little bit elevated, LDH is high, CK little bit, lactate 1.5, calcium, phosphorus, magnesium is okay, albumin. Yeah, doctor, but why is the needle? Say, well, I off to get a coffee now. راح اشرب كوبايه قهوه شكله كان فصل بقى خلاص ولا عملها. المهم and he tell nurse just to call nephro, thank you. خلاص لبست في النفرولوجي بقى. شوف النفرولوجي عندها فيها AKI وفيها كذا كذا. انا مالي يا عم حاول على النفرولوجي. ضريره ما تلاقي ER بيعمل لمبر بانكشر يعني. فالمهم يا سيدي اللي عندها ثرومبوتيك مايكرو انجيوباثي. دي ثرومبوتيك مايكرو انجيوباثي. الكرايتيريا فين؟ فيفر ولوس اوف كونشسنس وهايبوتنشن والكلام ده كله تمام. وAKI ثرومبوتيك مايكرو انجيوباثي TTP هيموريتيك روماتيك سندروم atypical HUS TMA endothelial damage Shiga toxin complement deficiency Fonwell brand not cleared Fonwell brand multimeres not cleared due to deficiency of this Adam TS13 intravascular hemolysis and cheering small vessel thrombosis multi-organ dysfunction. And did the pathogenesis of this endothelial damage we can discuss later in this separate presentation. This is a mechanism also. Criteria just for TTP for Bentad fever, thrombocytopenia. I will discuss all this in detail in separate videos. Okay, just we need to enumerate more cases for AKI. Bentad, don't forget Bentad fever. We have thrombocytopenia. We have hemolytic anemia. We have decreased level of consciousness. Already we have acute kidney injury. We have schistocyte more than 5%. All this criteria for TTP. Management don't get platelet unless acutely bleeding catastrophic. Even then, talk to hematology, consult hematology, nephro, and apheresis service. With especially urgent plasmapheresis, have low threshold for plasmapheresis. Dialysis may be necessary. Steroid autoimmune, eculizumab with atypical HUS. Okay, this is the main management for this patient. 78 years woman, next case, 78 women seen by family doctor for malaise. Hypertension, osteoporosis, the past medical history, medication, esomeprazole, Nexium, alendronate, amlodipine. Blood pressure is okay, a little bit high, with +1. I think this creatinine increased from normal to 318 over 3 months. Urine analysis, white blood cells, and white blood cell cast. What is the medication for her? She's medication esomeprazole, alendronate, and amlodipine with hypertension, +1 edema, and the creatinine increase from normal to 300. White blood cell cast culture is negative. Okay, this white blood cell cast, as we mentioned before. What are the other diagnostic modalities? Eosinophilia, urine for eosinophils probably not helpful, not sensitive. Eosinophilia, gallium scan and kidney biopsy. And eosinophilia, yes, in present, and eosinophilia, no number like that. Sensitivity, I think the sensitivity for urine eosinophilia is low than eosinophilia. And we are not dependent on that already, just to guide us if we have another specificity, just a sensitivity 31% for this eosinophilia, and just specificity 68%. And we'll see intrinsic renal disease to acute interstitial nephritis, the drugs, autoimmune infection, cancer. drugs causing interstitial nephritis, antibiotic, antimicrobial, beta-lactams, fluoroquine, sulfa, rifampicin, non-steroidal, diuretic, furosemide, thiazide, and trimetrin. All this can cause antimicrobial, now anti-inflammatory, and diuretic, furosemide, thiazide, trimetrin. All these drugs and AKI, acute interstitial nephritis, antimicrobial, anti-inflammatory, diuretic, BBI, allopurinol, also anticonvulsant, phenytoin, carbamazepine, Chinese herpes nephropathy. All this lead to acute interstitial nephritis. Okay. Treatment for acute interstitial, just to stop these drugs, consider short course of high steroid early as possible. If late, don't start. If you can start early, it's possible. Yeah, just 50 milligram per day, 50 milligram maximum per day for 7 days. As soon as this short course is good, if you will start early. But now the main treatment for acute interstitial nephritis is stop the offending medication, stop the offending drugs, and consider short course of steroid. Intrinsic, as I told you before, this is the most common disease in ICU, and you should classify according to anatomical location, as we mentioned, renal disease, vascular, or glomerular or interstitial tubular disease. Acute interstitial nephritis is a type 1 hypersensitivity reaction, classically with beta-lactams, ampicillin, and antibiotic, cephalosporin, fluoroquines, BBI. If you have systemic symptoms like rash, eosinophilia, white blood cell count, eosinophilia, usually occurs 4 weeks post-exposure unless previous exposure. Okay. Acute classic triad for fever around 70 to 100%, skin rash, eosinophilia, triad less than 10% in our patient. Fever, skin rash, eosinophilia. Fever, skin rash, eosinophilia. This triad for acute interstitial nephritis. Fever around 70 to 100%, skin rash around 15 to 50%, eosinophilia around 20%. This triad less than 10%. Drug-induced acute interstitial nephritis we mentioned before: penicillin, sulfa, cephalosporin, rifampicin, Cipro. Non-steroidal allopurinol, phenytoin, thiazide, furosemide, captopril, BBI. And this algorithm to manage drug-induced acute interstitial nephritis, the possible drug-induced acute interstitial nephritis, identify and withdraw the offending agent, supportive management, like that. If kidney function improve, continue observing. If kidney not improve, kidney biopsy. If more than 75% after conservative, if less than, you can start with short course steroid. Otherwise, best course steroid is sparing if steroid contraindicated, like cyclosporin or whatever. Acute kidney injury, intrinsic, having seclude pre-renal and post-renal cause, done 90% of your job. Embrace your senior and say you are looking for intrinsic renal disease. Great. Intrinsic renal failure. Again, we have level of injury, either tubular, ATN, ischemic, septic, commonest cause of renal injury, glomerular, acute, GN, least common cause, interstitial nephritis, drugs, toxin, vascular, like that. Please don't forget to examine your patient, assess the fluid status for your patient by vital, by examination, palpate, percussive bladder. Don't forget the bladder. Be alert signs of systemic disease, for example, rash, arthralgia, hemoptysis. Examine urine dipstick and microscopy. Management of AKI, initial treatment and investigation, treat the underlying cause if present. Treatment of sepsis by antibiotic and good hydration of vital triggers. If your patient is stable, please treat by an ICU under nootropic support, either norepinephrine and vasopressin. Don't forget to rule out obstruction by folic acid and ultrasound. Assess and correct the volume status, either hypovolemia or euvolemia, hypervolemia. Don't discuss with senior colleague, please. And this just 2 slides for trimethoprim and sulfa for mechanism for AKI. As we know that our distal tubules already have this inactive channel. Inactive channel, this is a tubular lumen which is responsible to take sodium from luminal to tubular cell to blood vessels. If we have this trimethoprim, he will work on this inactive channel. When you will take the sodium inside here, and this the room K channel, and this lumen will become more negative and here more positive, and the sodium from this sodium ATP is basolateral channels from the vascular side. This will get more sodium will come here and will go from this basolateral channel and will exchange with the potassium. We have here more positive and the potassium will be high positive here, and this lumen will be more negative, and this room K and this will go out and will be excreted in urine. If we have trimethoprim, will block this inactive channel already and lead to hyperkalemia. This is the mechanism of hyperkalemia of trimethoprim. We have trimethoprim or bacterium already three mechanisms. Either this hyperkalemia, this is one mechanism, and the other mechanism interstitial nephritis and impaired secretion of creatinine. This is three mechanism for trimethoprim. And other mechanism by decrease ammonium reabsorption result in decrease ammonium reabsorption and decrease medullary ammonium concentration. This also is mechanism, complicated mechanism for by hyperkalemia also, besides other mechanism. We'll discuss this also. We discussed already this, I think, in details in hyperkalemia. And the case number, I don't know, at 64 years, female patient recently started encephalexin for cellulitis. Came for reassessment 4 weeks later. After this cephalexin, legs looks great, breathing well, nauseous, itchy, tired, blood pressure is high, creatinine 800 from baseline 100. Just cephalexin and looks tired. Same type of hypersensitivity reaction as we mentioned before. This acute interstitial nephritis. And the etiology, drugs, infectious, idiopathic. This is just to enumerate all causes of acute interstitial nephritis. Treatment to stop the cause, consider just steroid if early as possible, otherwise don't start. Next case, 72 years women, fatigue, pale, hemoglobin 72, creatinine 310, urine negative depth for microscopy, ultrasound, kidneys 12 centimeter. The patient with low anemia and GFR, renal failure. The patient 72, fatigue and pale with creatinine 310 and anemia. Anemia and low GFR, renal failure, low hypoanemia. Disease cause both anemia and low GFR. Disease بتعمل لك anemia و AKI, either multiple myeloma, vasculitis, lupus, thrombotic microangiopathy. Low GFR, normal urine analysis, normal ultrasound Ki test. This is the multiple myeloma patient. Anemia و AKI, okay. Hypercalcemia cause pre-renal injury from vasoconstriction, myeloma kidney also precipitate free light chains, distal nephrons cause diffuse tubular obstruction, amyloidosis, precipitation monoclonal immunoglobulin in the glomerular cause of nephrotic injury, multiple other less common lesion, plasmacytoma, proximal tubular injury. All this we'll discuss in details in next presentation. AKI with oncology, next video. And in cases serum protein electrophoresis, serum free light chains, and urine protein immune electrophoresis. I discuss all these tests in details in the first presentation in onconephrology. And the bronchitis, diffuse tubular obstruction, as we mentioned, light chain disease, myeloma here, and uric acid and the drugs. Drugs زي ما قلنا السلفا والسيبروسايكلوفير, indinavir, and trimethoprim and oxalate, selinglycol. I saw one patient with diffuse calcium oxalate and vitamin C also. So we saw also same patient methotrexate, sodium phosphate laxative. All this is a differential diagnosis. Acute interstitial nephritis, as we mentioned before, either drugs are around 75%, infection 10%, interstitial nephritis, with uveitis 5 to 10%, systemic disease, Sjogren syndrome, lupus like that 10 to 15%. We can read this later. Drug induced, as we mentioned before, and this rash fever, eosinophilia, and rash fever, eosinophilia around 10%. Drug induced, we already discussed this before. And now we'll go to contrast induced nephropathy, just the definition. In case within 48 hours will increase the creatinine, your creatinine will go by definition of like acute kidney injury criteria within 48 hours. Either the definition serum creatinine increase by 1.5 within 7 days, or creatinine increase at least 26.5 micromole per liter within 48 hours, or urine volume decrease by 1.5 per ml per kg per hour for 6 hours. Definition, the contrast, I think we better to present one presentation for this contrast. Induced nephropathy, the main two mechanisms for contrast induced nephropathy, either by vasoconstriction or by direct damage to tubules. Okay, this is the two main mechanisms I need you to understand from this, either doing vasoconstriction or direct damage to tubules, as we discussed before. And the risk factor, presence of CKD, high osmolarity contrast agent, high volume already, more than 350, more than 4 ml per kg contrast, repeated administration. This repeated contrast is very bad by surgeon because he requests to repeat. Proceed, risk factor, BCI, and the arteriography versus CT, all this risk factor for AKI post contrast. And this, just to summarize in this table, especially the most important risk factor is CKD. Okay. And this contrast in AKI patient, I think any patient with AKI and receive contrast in ICU, no association between the contrast and the pattern of onset and recovery. The onset of AKI and recovery is other. We have multivariable regression causes, sepsis, metabolic disorders, other illness that will affect the recovery and the prognosis, not only the contrast. This is the benefit from the previous slide. Preventive strategies to give volume expansion, in-style cysteine, statin, all this debates and confliction, and this many studies done for that and no benefit to do. But I suppose for you, or suggest for you, just keep your patient good hydration, not pulmonary edema, not volume overload, but keep him in good hydration, at least by normal saline or isotonic bicarb with metabolic acidosis. And this just volume expansion, IV fluid, in-style cysteine, and stop other nephrotoxic medication as you can. IV sodium bicarb versus normal saline, as you can know, no benefit except if the patient has severe metabolic acidosis. Another case, 55 years CKD, creatinine 140, came with non-ischemic coronary angiogram, heart failure, diuresis, and AS creatinine 200 2 days. Non-ischemic hemodynamic instability, for the diuresis, contrast-induced nephropathy, cholesterol imbalance, differential diagnosis for this patient. You know, this patient post coronary angiogram, heart failure, and diuresis is already done cardiac cath and 2 stents done, and 2 days later creatinine 200. Non-ischemic with hemodynamic instability, for severe diuresis, contrast-induced nephropathy, or cholesterol embolism syndrome. In the contrast, pathophysiology, I told you the mechanism in the previous picture, intense vasoconstriction, from medullary hypoxia, lead to medullary hypoxia, direct tubular toxicity, and injury, both cause in 18. This is the main pathophysiology of contrast. I need you to understand, and don't read more, don't listen more. That pathophysiology for contrast. Intensive vasoconstriction causing medullary hypoxia, and this will lead to direct tubular also the one mechanism. And this second mechanism, direct tubular toxicity and injury, all this lead to ATN. Increase the osmolarity, increase the risk of AKI, and currently hyposmolar or isosmolar better injury manifests within 48 hours or 72 hours from oxybution. You need to observe the creatinine within this range to see your patient develop AKI or no, and the risk factor, as we mentioned. CKD is the most important one. CKD, where is the CKD? Estimated GFR is around the creatinine. This is the most risk factor. For the contrast, volume diabetes, anemia, age, chronic heart failure, intra-aortic balloon pump, also these other risk factors. And hypotension also is one of the risk factors. How to prevent? Just at least stop nephrotoxic medication, keep your patient euvolemic, no difference between normal saline or bicarb, in-style cysteine. Wallah, if you have facility, all patient can pay, just pay to at least to work as an antioxidant. As a statin, if your patient on a statin, this is good for him. As if you cardiac patient on a statin, this will help him. Cholesterol embolism syndrome, I think I have one presentation for that subject. Post any angiographic, post any cardiac procedure, just will be detached the cholesterol emboli towards the renal vessels, may also get a stroke, maybe seen 3 to 6 weeks, maybe within 1 month after the procedure, 3 to 6 weeks. Characterized by eosinophilia and low C3, hypocomplementemia, low C3. Cholesterol emboli post any angiographic or any cardiac intervention, just detach it or dislodging this cholesterol emboli toward the renal vessels, may also get a stroke. Maybe you will see in 3 to 6 weeks post procedural eosinophilia and hypocomplementemia C3 is low, And the picture is livido reticularis already seen, and the patient was antiphospholipid syndrome or whatever patient with cholesterol imply, and this trashed feet already, the peripheral ischemia already, and this hole in Horst plaque already in fundus examination, hole in Horst plaque, hole in Horst plaque, hole in Horst plaque. We will be asked for that. And livido reticularis, trash feet, and fracture this cast, fracture the cast within the blood vessels in kidney biopsy. Another case, already 75 man, emergency department, not feeling well, basal chronic CKD and creatinine 170, came by creatinine 700, from 170 to 700. What is the AKI? What is his risk factor? This patient 75, emergency, not feeling well, just from 170 to 700, I afraid this patient will be post-renal, yeah. This elderly male patient, he came not feeling well, CKD from 170 to 700 means obstruction على طول, elderly male patient. Those post-renal obstructive uropathy, older men, BPH, a woman post-pelvic uterine surgery, you should suspect that patient with solitary kidney congenital surgical removal transplant, increase the pressure in the lower urinary tract, reflected back to Bowman's space, directly opposite glomerular filtration, vasoconstriction signal sent to the afferent arteries, decrease in GFR, decrease in the GFR. All this from the pressure inside the lower urinary tract, reflected to back pressure in Bowman's space, directly opposite glomerular filtration, vasoconstriction signal sent to the afferent arteries. All this will end by decrease the glomerular filtration rate. Ultrasound or CT, the better technique to assess hydronephrosis or obstructive uropathy. Treatment relief obstruction either by stent, nephrostomy, whatever, folic acid, percutaneous nephropathy, stent, whatever you like. Concerning post-obstructive uropathy, the complication of treatment of obstructive uropathy, post-obstructive diuresis, potentially leading to hypovolemia and worsening of AKI, reason for high urine output, post-relief obstruction, empty enlarged bladder, excrete retained sodium and sodium chloride water, and high urea, also osmotic diuresis, tubular injury. You know, afraid from this patient and if tubular injury, nephrogenic diabetes insipidus, excretion of fluid administration to prevent volume depletion. The risk of this patient will go to severe volume depletion from osmotic diuresis and tubular injury, nephrogenic diabetes insipidus, and maybe will go to hypokalemia, hyponatremia. You should follow electrolyte and the volume status for your patient and should replace this polyuria for that. Look, you will monitor the volume depletion. You can replace 1 to 1 first day and keep 1 to 2 next day by half normal saline, please. And assess the sodium and potassium and replace all that, okay? And just to continue monitoring the urine output and the volume status for your patient. Post-renal less common 2 to 15%, hallmark ultrasound, post-voidal residual more than 50. You know, obstruction lead to increase in intratubular pressure, and this will lead to, at the end, decrease in GFR. If obstruction prolonged, it will lead to intense renal vasoconstriction, persistence lead to persistent GFR, low GFR. Obstruction must be bilateral to produce significant renal failure, not unilateral, except if you have a patient with single kidneys. Obstruction present with no urine flow, anuria, or intermittent urine may be also present in non-logoric AKI. Obstruction is most common cause of anuria. Effect of obstructive nephropathy on glomerulus is first few hours just increase the intraluminal pressure, transfer to renal tubules and Bowman space, decrease the filtration pressure in the glomerular capillary. As we see here in the first few hours, this pressure already transferred to tubules and lead to increase the pressure in the Bowman's capsule. After that, we'll go to glomerular capillaries and decrease the glomerular area of filtration and lead to more vasoconstriction leverant arteries, decrease the blood flow, and ended by decrease the GFR. And here in the proximal obstructive nephropathy and proximal convertible reabsorption will increase sodium reabsorption and decrease the arterial branching here. And it also in LIBOF only just decrease sodium chloride reabsorption and decrease the water reabsorption, decrease the medullary retonicity, decrease the sodium ATPase, decrease the calcium magnesium. All this secondary effect from this obstructive nephropathy, collecting duct all will be decreased also. Multifactorial, as we mentioned before, seen only in bilateral obstructive urinary obstruction, but not in unilateral urinary obstruction. except if the patient was single kidney, post-renal obstructive or ureter, whatever the cause, outlet obstruction, whatever the cause, urethral obstruction, whatever the cause, post-renal obstruction, in derangement of tubular function that affects sodium and water handling. In general, there is impairment tubular sodium reabsorption, urinary sodium more than 40 milliequivalent per liter, water reabsorption. Typically, the friction excretion sodium is more than 2 in post-renal. We have one case, 73 years, female, transplant 2011, creatinine 140, and well, AX, creatinine 250 from 140. And this patient, I think we did ultrasound. We found this ultrasound, the hydronephrosis, this is obstructive nephropathy post-transplant. Rhabdomyolysis syndrome characterized by muscle necrosis and release of intracellular muscle constituent, including the myoglobin. This from inside the muscles. Already you will see under microscope too may cause AKI. The presence of heme pigment by positive blood test in the urine. Without microscopic evidence of red blood cells, rhabdomyolysis suggests, without microscopic evidence of red blood cells, suggests rhabdomyolysis or hemolysis. If you will found positive blood test with urine dipstick without red blood cells, this suggests rhabdomyolysis or hemolysis. Okay. Abdominal compartment syndrome refers to organ dysfunction caused by intra-abdominal hypertension. Physiology consequences include impaired cardiac function, decreased venous return, hypoxemia, hypercapnia, renal impairment, diminished blood perfusion. Risk factor for intra-abdominal hypertension, high volume resuscitation, decrease in abdominal wall compliance, increase in abdominal content, certain ascites or large neoplasm or pancreatitis. What means by normal intra-abdominal pressure less than 12 from 5 to 7 millimeter mercury, intra-abdominal pressure more than 12, acute compartment or intra-abdominal hypertension more than 12 millimeter mercury, acute compartmental syndrome, blood pressure, intra-abdominal pressure more than 20 millimeter mercury, abdominal pressure perfusion pressure, this mean arterial pressure divided by intra-abdominal pressure, target more than 60 millimeter mercury. This abdominal perfusion pressure, mean arterial pressure minus intra-abdominal pressure should be more than 60. And this is just measure how to measure by this Foley catheter and monitoring here and the screening. Just as a method I didn't use before. I didn't know, just to measure the intra-abdominal pressure by this catheter. As we mentioned, intra-abdominal compression syndrome, etiology is massive fluid resuscitation, or patient already his abdomen with tense ascites, bowel distension, or with maybe polycystic kidney disease, pancreatitis, intra-abdominal peritoneal bleeding, retroperitoneal aneurysm, or pelvic fracture with bleeding, or pancreatitis, severe burn also. And the systemic effect, systemic effect of elevated intra-abdominal pressure, central nervous system lead to increase intracranial pressure, cardiac hypovolemia, decrease cardiac output, renal decrease renal output, renal blood flow, pulmonary increase in intrathoracic pressure, airway pressure, gastrointestinal decrease celiac blood flow, hepatic decrease in portal blood flow, abdominal wall decrease compliance, intra-abdominal compression syndrome, renal consequence, renal vein compression, impaired venous drainage, renal artery constriction also will by stimulation sympathetic and RAS system, oliguria generally develop at intra-abdominal pressure plus or minus 15. And urea if intra-abdominal pressure plus or minus 30. These changes are reversible if intra-abdominal recognized early and decompression is performed. Don't forget this is the mechanism most important: renal vein compression, renal artery, renal vein compression, renal artery vasoconstriction by stimulation sympathetic or RAS, oliguria لو intra-abdominal pressure 15 or anuria if double 30. These changes will be reversible if early management of this intra-abdominal pressure. Release from muscles, as you know, international recommendation for the patient with crash victim or crash injury. You know, the patient will release the potassium, phosphorus, myoglobin, uric acid, CK, this will be high. You need aggressive IV fluid, isotonic bicarb 1 liter per hour during resuscitation. Just will assess him until the patient will be hypervolemia. We can start Lasix, and if the patient refractory, we'll start just renal replacement therapy for him. And try to treat acidosis as you can. Rhabdomyolysis, you can use isotonic bicarb too. You can use also mannitol is controversial with alkaline with isotonic bicarb. And urgent fasciotomy if you think intracompartmental pressure exceed 40, this need urgent fasciotomy. And otherwise, if it's refractory to all this, potassium, phosphorus, and others, you need renal replacement therapy. And this criteria for tumor lysis syndrome: high uric acid, high potassium, high phosphorus, and low calcium. And tumor lysis syndrome need aggressive IV fluid, and just 2 to 3. يعني they keep urine output more than 2 liters per day or 2 to 3 liters per day. And we'll discuss all this in an AKI presentation with cancer next presentation. And with another management for tumor lysis syndrome, allopurinol and alkalinization, we have to more details for that to use or no, especially if patient is hyperphosphatemia. This can precipitate calcium phosphate stones. Allopurinol we should use 300, otherwise we can use 300 to 600 at least, and the raspberry case also the second choice. Aim to keep urine pH more than 7. Hemodialysis if refractory, any other electrolyte or acidosis or volume overload. All this will be discussed in next presentation. Raspberry case also is urate oxidase enzymes. This converted uric acid to allantoin, more soluble form of uric acid. And contraindication G6PD deficiency or pregnancy or lactation. AKI critically ill cancer patient, AKI in cancer patient either from sepsis, tumor lysis, kidney damage, AKI from cancer itself, and AKI in equilisis. This will be discussed in next presentation. And this also I will discuss in next. AKI either related to cancer, hypercalcemia, intravenous contrast, treatment-related sepsis, volume depletion, hepatic sinusoidal obstructive syndrome. We'll discuss in next presentation in oncology video, tumor lysis syndrome, proximal tubular, multiple differential diagnosis, and this related to tumor type. Prevention AKI again. This slide I don't know why disappears. Don't forget warfarin-related nephropathy. This I already seen in patient with nervous system. The association between the anticoagulation warfarin and AKI due to comorbidities. Association between anticoagulation and warfarin and AKI due to multiple comorbidities, kidney hemorrhage and cholesterol embolism, allergic interstitial nephritis. Just not to forget any patient with warfarin toxicity with high INR. With this associated multiple comorbidities, kidney hemorrhage, cholesterol embolism, or allergic interstitial nephritis, all this precipitate warfarin-associated nephropathy. Many erythrocytes in the Bowman's capsule and renal obstruction due to erythrocyte cast leading to ATM. Susceptible with patient hemorrhage or hematuria. Other risk factor multiple comorbidity for this patient will precipitate this warfarin toxicity already. Just I need you just to remind you this term for patient to have AKI by cardiology and given warfarin with high dose, with high INR level, just put in your mind this. It is starch we can use in ICU, but is patient with severe sepsis has been associated with AKI more likely require nervous increased risk of death at 90, and the risk of bleeding also with high chloride with this heated chart. High chloride containing solution like normal saline. This will increase hypercholoremia, will lead to increased risk of acidosis and increased risk of vasoconstriction. Also, increased chloride delivery to macula densa. This lead to aberrant vasoconstriction, decrease the GFR. Better to use a balanced solution or low chloride container. Nutritional, as we know, general basic 20 to 30 kilocalories per kg per day required. Avoiding restriction for protein intake, especially in patient in ICU. Give 0.8 to 1 gram per kg per day protein, non-catabolic AKI, or patient already renal replacement therapy 1 to 1.5 gram per kg per day. Provide nutrition prevention via enteral tube, not parenteral. Early parenteral feeding lead to increased risk of infection, delayed discharge from ICU, higher incidence of cholestasis compared to the late parenteral. Enteral nutrition is very variable and has fewer complications than parenteral nutrition, just to remind you. Indication for starting renal replacement therapy, as we mentioned before, uremia and refractory electrolyte, as we mentioned, or refractory volume overload. All this you can read already. which modality for renal replacement therapy, whatever available, except if the patient hemodynamic and stable, please CRRT. If you don't have CRRT, SLED I think is better, and intermittent hemodialysis preferred for intoxication. Otherwise, SLED also SLED preferred in patient with cerebral edema or brain injury, and I think great benefit between SLED or CRRT, but CRRT preferred in brain if you have, CRRT preferred in patient with hemodynamic instability if you have machine and nurse, otherwise you will use SLED. As I mentioned before, no difference, and only in brain injury better to use CRRT and the hemodynamic unstable, otherwise no difference. AKI in ICU is a common cause of mortality, even if minimal rise in creatinine. Acute interstitial nephritis is the most common, delayed parenteral better, and enteral feeding very favorable than delayed parenteral. CRRT is preferable for patient with hemodynamic instability or brain injury, but intoxication better to use LIHD. Isotonic crystalloid, patient with hemorrhagic shock, patient with liver disease, norepinephrine is safer than dopamine. Amyloid oxide should be avoided. Use loop diuretic with mannitol, or low dose dopamine. And just a trial, septic AKI, infection, diarrhea management, supportive care, and renal replacement therapy when indicated, and follow up. Earlier, just in therapies for AKI, earlier treatment of sepsis better, balanced crystalloid solution better than crystalloid, even isotonic bicarb better from all. And this salted saline, smart balanced, I think there's little no difference between both. Just at the end, the balanced I think is better than the saline one. Balanced is ringer lactate better than this, and the bicarb, the isotonic bicarb better than all in everything. If you see numbers here and the significant difference when composite primary outcome, no significant difference, but the composite outcome significant difference with B 0.1 in mortality. I think here bicarb, isotonic bicarb is better solution to use in AKI, especially with severe metabolic acidosis. Fluid overload طبعا associated with high mortality, negative predictor of recovery of renal function. This is a very bad note. We don't like fluid overload in our patient in ICU because this leads to renal venous congestion, abdominal compartment syndrome, destruction of the glycocalyx, and the cytokine activation. All this will aggravate your acute kidney injury. Don't overload your patient in ICU. And the mechanism of sepsis and normal septic AKI, fluid resuscitation, and the net effect here, tubular damage and organ edema, microvascular abnormalities, and diureticity. All this will end by decrease the GFR and will end by all this dilemma of our kidney injury. And the clinical assessment of fluid overload, I just put this picture. You can check later to put your GVB, chest examination, abdominal, lower limb, and everything you can examine, or systemic hypotension, to remind how to can assess your patient volume status, either hypervolemic or euvolemic. These are also other measures you can read for volume assessment. Potential indication of renal replacement in ICU, refractory hyperkalemia, refractory severe acidosis, clinical significant organ edema, uremic encephalopathy, pericarditis, neuropathy, myopathy, severe dysnatremia, intoxication, also methanol, lithium, metformin. All this indication for dialysis in ICU. What is your role? Nephrologist in ICU. A nephrologist taking care of critical ill patient in early stage of AKI and lower incident progression to severe AKI and lower mortality, and enhance the patient recovery. A nephrologist also provides this dialytic dialysis prescription, and the mode of dialysis and transition from one mode to other is only done by nephrologist. Better to involve nephrology, nephrologist early stage of AKI, better than late stage. Early follow-up by nephrologists after AKI episodes in those requiring replacement therapy with improved survivor. Nephrology will try to avoid dialysis for your patient and try to enhance his recovery. In nephrology will adjust the best mode or write or prescribe the best mode for your patient in ICU. In nephrology will shift the patient from one mode to another mode according to volume status and the recovery. In nephrology will follow your patient recovery status and plan to stop dialysis or continue, and plan for follow-up, and plan to avoid more frequent future admission again by AKI again in future, or re-deterioration of his AKI after recovering also. Prognosis is spontaneous recovery, just usually heralded by increased urine output and a gradual decrease in BUN, serum creatinine to return to baseline function. Some may end with CKD, other will end by dialysis dependent. AKI is common, particularly in hospitalized and ICU patients. Recognize volume responsive, volume non-responsive AKI. Prevention is vital since only a few therapies are proven to reverse the AKI. Careful follow-up post-AKI resolution is necessary. And this fast test, this furosemide stress test, as we mentioned before, will give just to test your patient's renal or perirenal will improve or no with diuretic, just to give for naive, not received the Lasix before, 1 milligram per kg IV bolus, or this patient received if the patient received furosemide, just to give 1.5 milligram, and we'll see urine output in the next 2 hours. If perirenal oliguria will bring urine, if renal will not get amount of urine of more than 200 with this perirenal, replace the urine output and temper further hemodynamic, just to continue conservative management. If the urine output less than 200 means renal problem ATN, and he will take time, just proceed to dialysis for this patient. Just a key point to remember in AKI, referring to nephrology, if you meet this criteria, there is a clear cause of AKI and the condition is responding, but if the patient responding and the clear cause of for AKI, I think you don't need to refer to nephrology. Considering discussing management of patients with severe illness, I also refer if unexplained AKI or not resolving AKI injury and how to manage. Discuss the management of acute kidney injury with nephrologist. Within 24-hour detection, one of the following possible diagnosis of secondary cause GN, interstitial nephritis, myeloma, AKI, no clear cause, inadequate response to your conservative management, complicated associated AKI, CKD stage 3, or chronic kidney disease 4 or 5, estimated GFR less than 30. You should all this direct to call nephrology for that. When to revere in practice high-risk AKI patient, as patient with high-risk patient with CKD4, potential requirement for dialysis, either any indication for dialysis as criteria we mentioned before. Possible treatable intrinsic renal disease, please send it to nephrology. No obvious cause of AKI, please refer to nephrology. Summary, AKI is common. AKI due to acute and long-term morbidity. Many causes of AKI can observe it and can deal with that. Systemic approach needed to reach to your diagnosis. Dialysis whenever indicated. Certain specific cause have a specific treatment. Approach to pre-renal, post-renal, and renal cause. Rule out obstruction. Manage volume status. Dialysis when needed. Cause of AKI. Your practical approach, and this investigation and management of AKI with the comprehensive clinical nephrology and the approach. If you like to read this approach also, just I try to collect everything as possible for you. In summary, preventing AKI remains one of the most important interventions in AKI care. Remember the rule of nephrologist. Don't forget nephrologist. Nephrologist will try to stabilize your and enhance the recovery of your AKI. If you need dialysis, he will choose the best modes and modality of dialysis for your patient, and when to change, how to prescribe the wise prescription for your dialysis patient in ICU, and when to shift from one mode to other, and when to stop dialysis. This also should be, all this is the job of nephrologist. AKI associated with both short-term mortality, rehospitalization, long-term risk factor, CKD, and renal disease. AKI follow-up clinics we have AKI clinic post AKI recovering, just for blood pressure control, glycemic control, treat with RAS inhibitor for patient with proteinuria, avoid any nephrotoxin contrast, and any new medication dose adjustment for that. And don't forget this practical approach to AKI. First, you have AKI or no by definition, as we mentioned before. If your patient is stable or no, your patient hemodynamically stable or no, ABC medicine. If the patient obstructed or no by folic acid, ultrasound, your examination also. If no obstruction, acute indication for dialysis, as we mentioned before, after your conservative treatment. If no acute indication for dialysis, patient perirenal is either volume depleted or volume overload, and if volume depleted will give IV fluid. The best one is isotonic bicarb. Otherwise, if the criteria for perirenal fraction excretion sodium less than 1, low blood pressure, history of volume depletion, if extra vascular volume overload, congestive heart failure will deal with that, and the hepatorenal will do MAO, and this was diuretic inotropic support by ICU. If a patient not volume depleted, this means a renal problem. We'll send you a microscopy with different type of cells and the cast, GN workup, CK for rhabdomyolysis drug, blood smear, protein for this differential diagnosis, interstitial nephritis, GN, TTB or HUS, cholesterol imply syndrome. And this some reference, if you like to read more, you can take copy and you can read to enjoy by more AKI. ودائما الحمد لله والشكر لله على كل حال، ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونسألكم الدعاء بالتوفيق والسداد. أنا حبيت ألم ليك just superficial by cases, by all cases, and how you can deal with any case with AKI. And in future presentation, we can present each subject in separate by some details, some more explanation. And I prefer to present today this presentation before AKI was cancer in next presentation. I hope everyone had some benefit today to our patient. ولا نسألكم غير الدعاء بالتوفيق والسداد والصحة والبركة في المال والأولاد والأهل. والسلام عليكم ورحمة الله وبركاته. ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونترككم في رعاية الله وحفظه.